It's my pleasure to welcome all of you. And this is a tribute to, of course, Manfred, but also for everything he has done leading the leadership of the IUSG for so many years. And I am proud to belong to the first generation at the IUSG. This is something that happens with age, with time. And I've been following what happens in the IUSG now for 40 years. I've seen Manfred come to the field. I've seen him working very hard in different positions, always trying to improve knowledge and education regarding the uveites, immunology, clinical and surgical ophthalmology. Also, with time, he moved to more important positions at the organization, and he has, since the beginning, tried to share his constructive vision and share to everybody. I believe that we're gonna see today, and Eloisa and Christina will point out some important aspects, is part of Manfred's vision. And the idea of having this tribute coming originally from the Brazilian, the Latin American fellows of IUSG is to stress the appreciation we have for Manfred having always been a champion, trying to disseminate IUSG membership to the different countries. I'm gonna have a few slides trying to describe what I have comment first. Can you see my screen?
Yes.
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 Yeah, so for the guys that are not member of the IUSG, it's important to remember that it was founded in the 70s, and it was a very small group of people coming basically from continental Europe and the United States. I was fortunate to become a member since the decade of 1970s, 1980, and had the help of Miguel Burnier since the first years. Miguel, much younger than me, was already aboard. And we have seen the membership in Latin America increase. And as far as I know, this is the membership, and we have Argentina, Cristóbal Couto among us today. Emilio Dodds cannot be here, Manfred, because he's traveling right now, and he sends his regards. And we have a nice and excellent group from Brazil, also with André Cury, Cristina Muccioli, Heloísa Nascimento, Fernando Orefice, Cláudio Silveira, Daniel Vasconcelos, and Joyce Yamamoto. Of course, Miguel Burnier from Canada, and Fernando Arevalo from Venezuela, Lourdes from Mexico, and Alejandra from Bogota. So we do have a nice group of people, and it's important to remember, if I can move my slides, Ricardo.
Doutor Rubem, precisa colocar um pouquinho mais para baixo, por favor. Clica em cima do slide. Isso.
It's not. This was the first official activity of IUSG in Latin America. It happened in Brazil in 1988. After many years of discussion and planning, the IUSG decided to have a meeting in Latin America, trying to invest in different countries. And as you can see, the main topics at that time were already present in what we discussed today. Ocular toxoplasmosis, viral uveitis, at that time represented by AIDS, advanced diagnosis and treatment, basic research, surgery, and case presentations. And this was done in Venezuela. the program, the scientific program of the meeting already included people from different parts of the world. And we had Manabu Mochizuki in the program, as well as many important people of Europe, United States, Asia, and also Brazil. Here you see that the first meeting was held in Espoo, Finland, by Matti Saari, and 4 years later, Guarujá. And then we have all these meetings listed in my slide here, showing how important it is to have the different congress and symposia in different parts of the world. Also, you see here people from Austria, Belgium, Brazil, England. Many of them are not in the field anymore. We still have Matti Saari, that was the first president of the International Symposium. IUSG would never happen if we did not have Bloch Michel. Bloch Michel was a very interesting professor. Actually, he was not a professor. He was very interesting ophthalmology from Paris, and probably would never happen again with a president, a leader that would not speak a good English. Bloch Michel did not pretend he spoke English. He was very fluent, of course, in his French. He had a very global mentality, and it was part of the membership to know French enough to talk with Bloch Michel. I used to say that every time I try to speak in French with my friends, they say, please go back to English, go back to English. And at that time, it was different. We had to speak some French in order to communicate at the IUSG level. And since the beginning, also, we had the excellent people from different parts of the Europe. And as I said, Manabu Mochizuki, Shigeaki Ono, Professor Aoki Usui. Switzerland, we had Martinet. Martinet was also a very strong lady. I would say that Martinet was the first strong lady at the IUSG. And she always fought for having other women present. And they're talking about 1970, 1980. And from the United States, we still have Hank Kaplan working hard in uveites in the field, but we lost many of them. We thank God we have Kaplan, we have Narsi Rao, and we lost some of them because of age and also because of the disease. And I believe that none of us can talk about uveites and immunology without celebrating Robert Nussenblatt. So this was the beginning. And in 1988, we already published proceedings of that. It was a very thick book with hundreds of papers that were presented there. And I believe this is also something that IUSG should be very proud. Also, I followed all these years what happened at IUSG. And as I said, I saw all the work that Manfred has done on behalf of this group and uveites. Manfred worked very hard and organized many important education symposia. Cristina Musoli and I believe that representing Brazil, represented at that time Latin America, were present in many of them. Constance, and meetings, some of the best meetings I attended in my life were organized by Manfred. He would have meetings with maybe 20, 40 people for 2 days, organized in a very German, hard style, and excellent education, bringing people from countries like Turkey to discuss budget and things like that. So Manfred was good on that, and also organizing different aspects of the group, including the recipients of the Schlegel Richard O'Connor Medal that you can here see listed, and I'm very proud of being one of the recipients. So this is all that I had to say in order to officially open this meeting. And I believe that we are very happy in having Manfred aboard and continue to share with us his vision and improve what happens in the uveites. And we're not talking about 2022, we're talking about the future. Manfred, I believe, represents the past, the present, and also the future of the uveites in the different parts of the world. And very special, Manfred, your interest in Africa, in Latin America, in Asia, in Russia, and other parts of Europe, and in a few words, making the different levels of the world get together. Thank you very much. And I'd like now to introduce Heloísa Nascimento and ask Heloísa Nascimento to chair this meeting, also making people not to work too much. Heloísa, go ahead.
Thank you so much. I'm very honored to represent the Brazilian Uveitis Society, which was represented by my tutors, Professor Belfort and Cristina Mocioli and Miguel Bonnier before. And so this is the first of our meetings this year. And we thought that the best meeting would be a tribute to Manfred. So talking about the Brazilian Uveitis Society, it was, it has its beginning in the 70s and in the 80s, just like IUSG, with Fernando Refsi and Rubens Belfort. And they had many really important presidents here in Brazil that helped us to structure this uveitis society. Those are all the presidents. And talking about our Federal University of São Paulo, which we work and we see many patients with uveitis, and that for sure, Manfred, many things that you taught us, we use on a daily basis, and showing and also saying thank you to Cristina and Belfort, who indicated me for the Venice course of 2011 that changed my life. And this is Carlos Eduardo Souza, who is the next head of the uveitis department from the Federal University of São Paulo. And this meeting is also held by IPEPO, which is a Champalimau Award winner philanthropic institution that makes many educational and assistance to poor people, and has many doctors and residents, and education is a priority. So this is me in the Venice course of 2011, and I would like to thank again Professor Manfred that gave us this opportunity for some countries they gave a grant, and I was there with a grant. Here is behind me, and it was a game changer in life, because I came back of this week of immersion in uveitis, came back with a very passionate. So now we decided to be simplifying uveitis. And how would we simplify something that is so complex? And so I prepared some of the pictures that we had, that in the first look that we could say, in the first picture, it is an herpes because of the positive transillumination, something that is simple and that can be a tip. In the second, of an acute retinal necrosis. And in the last, this patient with relapsing polychondritis that was admitted in an intensive care unit, and they didn't know what they had. And then the ophthalmologist entered and say that it is a relapsing polychondritis because of his ear. So those tips made it a little bit more simple to us and more simple to teach. And Manfred was someone that really loved what he has done always, and the uveitis. And so I thought it would be an interesting slide for us to finish. That is, choose a job you love, and you will never have to work a day in your life. And this is our Unifest Many People uveitis team, and we love seeing about 70 patients, uveitis patients per day. And now, on behalf of the Brazilian Uveitis Society, we are going to meet in person, I hope so, in June of 2002. So thank you.
Very good. It's important to say that we already have 85 people aboard, Manfred, and coming from different parts of the world. There are so many friends we see here coming from South Africa, Derek, and different parts of the Asia. So great. All of you, welcome. And this is part of Manfred has given to us. And we're very happy to give a little bit back to you, Manfred. So go ahead, Christina, please.
Okay, so it's the time to use my eyes to pay a tribute to my dear friend, Professor Manfred Zierhut. And I would like to start, remember that besides medicine, Manfred's education was in chemistry, and then he did the residency in German, and then moved to US for a fellowship at the Mass Eye and Ear, and he is the president of the IUSG. So he is a member of many international societies, but most important, International Ocular Inflammation Society, Tear Film and Ocular Surface Society, International Behçet's Group, Society of Ophthalmo-Immunoinfectology in Europe, and the Deutsche Ophthalmologische, and this word that I can't pronounce.
Bota o chat, bota
Very good.
So he wrote his habilitation in immunology of herpes simplex virus, and he is the president of the International Uveitis Study Group. He was past president in 2009 and 2013, and he is the president now. And he is the editor-in-chief of the Journal of Ocular Immunology and Inflammation. Well, we all know. Well, somebody has to close the open audio, please. And his field of interest includes all types of extraocular, dry eye allergy, and intraocular inflammation and infection of the eyes. So he's a very heavy publisher and book chapter writer and editor. So he has more than 200 publications, more than 1,000 lectures. He edited a lot of books and chapter books, and he organized more than 45 congress, workshops, and meetings. So he has a huge scientific contribution for medicine, ophthalmology, and we all know Manfred by his work in ophthalmology, many books, many papers, and so many meetings, so many friends, so many students, and all over the world. And we do have so many patients, and we have this special patient that asked us to pay a tribute for Manfred. And here it is.
Chris?
With no voice.
No voice, Chris.
Okay. Não tem
Now
áudio?
it's coming. No sound, Chris.
For me, it's perfect. It's not working for you?
No.
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 It's not gonna work, Chris.
Okay, so I'll send you the audio later on, but he was just saying, he asked, he's now Luciano Peixoto patient, and he's saying that he's thanking you because he has a normal life, and he would say thank you, and I think he is here, listen to the meeting. So I will send you the audio later on. Sorry about that. I'm listening perfectly. And okay, let's go over. And I'm saying that Manfred was in the four corners of the world, not only as an ophthalmologist, but as a very good traveler. He is a very, very good photographer. He has a very good taste for art and music, as well as astronomy and enology, and he is an adventurer person. So, and today I have the honor to pay a tribute to such an amazing doctor, and most important, amazing dear friend. During the past 30 years, I was following and admiring his career, lectures, books, meetings, patient education, travels, and I can tell without a shadow of a doubt that he was an inspiration for many of us, not only by his brilliant career, but for all the teachings beyond ophthalmology and inflammation. And here I'll give you all my gratitude. And I want to remember when I was in ETAL meeting and you invited all of us to go to the Zugspitze, and I was like dying inside this cable car, and you're there like watching and say, "Are you okay, Chris?" I was like pale, and you're
Tá, dá
there
uma
like
lida aqui nesse tamanho ali para ver se tudo ficou.
helping me and make my way to the top of the Zugspitze possible. And then also you introduced me the castle and Neuschwanstein Castle, and you taught me that it was the inspiration for the Cinderella's castle at the Walt Disney World. Also, you invited me to know the wonderful San Salvador Island in Venice, where my roots came from. I have my family came from there, from Veneto. And also, it's very good to talk with you because you're very open-minded. And we were talking about this lifespan, this book that for you and me, like a kind of changed our life. So you're always ahead of the ideas, and you have many good ideas. And beyond everything, you have a Brazilian soul. So, and maybe I can say you have a Brazilian heart. So you've been to Brazil many times, like to São Paulo, Bahia, including Carnival, Rio de Janeiro, and Iguazu Falls, that I know that you love Iguazu Falls. And maybe your heart beats more for Minas Gerais because of Milton Nascimento. And here I can teach all my friends that if you want to see a German happy, give him caipirinha. Here is the proof that you were very happy and you're drinking caipirinha. So, and what else? What is more important in life? Family and friends. And here's another side of you, like with father and grandfather, and always with your family and always with your friends. So
Chris, I think you're gonna have to sing.
It's not.
No, don't do it. Don't do it. Don't do it.
No. Well, I was planning to invite Milton Nascimento to sing for you, but you know, he has a very tight agenda. So unfortunately, the video seemed that didn't play, but I want to tell that you created the IUSG club, like the Clube da Esquina. So, and I will say thank you for so much. Thanks for being an amazing doctor and friend. And thanks for always being in Brazil. And I want to propose a toast. We can't have champagne right now, but you in the North Hemisphere are able to. So thank you, Manfred. It's my tribute for all I learned from you. Thank you.
Thank you
Thanks
very
so
much, Christina. This is an emotional presentation, and of course, we all share that. Manfred has really, as this last slide shows, has made what we dream in reality. And now going to the scientific program, I'm very happy to have the first speaking being André Cury. André Cury belongs to the youngest generation, the IUSG, and he's going to talk about emerging uveites. Thank you, André.
It's a pleasure to be here. Manfred, it's a pleasure to honor you. You know, you helped me a lot, and I was really shocked when you came to Brazil, when I called you in 2012, and you said that you've been here so many times, and I realized that you know Brazil much better than I do. So it's interesting. I'm trying to share the slide.
You know, it's good when I see young guys having the same problem that I have.
Yeah, I know.
As an old guy, it makes me feel younger, André. Thank you very much.
Yeah, I know.
Take your
It's
time.
8 o'clock in the morning.
Take your time. We see so many people in the screen that it's good to have some time to look at them. I see Claudio Silveira. I see people from different countries, different continents. This is also because of Manfred. Now you are on. No, you're not on. Yeah, now you are.
You can see here?
Yeah, perfect, André.
Okay. So I'm sorry I have to start the educational part of the meeting. And so I'm going to talk in the emergent uveitis. Actually, I'll do some few comments on some disease, and then I will focus on a special disease that are increasing in Rio, especially, and I think we will spread for all over the country. So for the last years, you've been seeing dengue, Zika, chikungunya, West Nile virus, yellow fever. And in 2014, we had the first detection in America of Zika. And the group of São Paulo going to work in the northeast of Brazil, they detected Zika in the eyes, especially in children, and was really a great outbreak that we had in Brazil and then spread all over the world. And it's important to say that Zika, the best option is to do the PCR within the 3 days, and the positive in the blood after 7 days is very small. So you should test the patient within the first 3 days. So this is the first documented case of Zika uveitis in adults, and was made by a friend from Brazil, João from USP, Ribeirão Preto, and he presented this case, and he did the PCR in the AC and detected Zika virus in the first case in adults, because at that time we felt that only children was affected by Zika virus. Very few cases in adults were reported. So you can see here in 2016, 17, 18, but amazingly, it's just one case a year of Zika virus in adults. And we had this patient, a 37-year-old from Rio with blurred vision for 10 days, fever, papillary hash, arthralgia, no systemic disease, and visual impairment. And you can see here in this autofluorescence image that you can see this hyper autofluorescence, and the OCT shows some changes in the outer retina, and was positive to Zika, and the diagnosis was multifocal choroiditis secondary to Zika virus infection. And here is after 2 years, and the visual acuity back to normal. You can see here from 2016 to 2018, and the vision was completely recovered. So this was a great endemia at that time. And then we had the outbreak of yellow fever in 2018. And one disease that we felt that we only have in the Amazon or in the center of Brazil. And then suddenly we had in São Paulo and Rio. And you can see here many parts of, this is Rio de Janeiro state, and many parts of Rio, we have really very bad cases of yellow fever disease. And many ocular findings were described by the group of Brazil. So this is a group from São Paulo, Zin, and a group from Belo Horizonte, Vianello, and they describe anterior uveitis, choroid detachment, venous tortuosity, maculopathy in yellow fever disease. And then the group of São Paulo, led by Daniel Vasconcelos, a very good friend of us, and he will talk later. They published a long, a very big group of patients with yellow fever, actually 64 patients with yellow fever, and 13, almost 20% of the patients present with retinopathy. Those slides from Daniel from the original paper, JAMA, and you can see here some hemorrhages, some retinopathy in the inner retina. West Nile virus is a condition that you can see more in Europe and in United States. Those slides are courtesy from Professor Monsef Karla from Africa. And this is very typical of West Nile, this choroiditis that come along from the nerve fiber layer. And it's important to say that 8% of the patients with neurological disease can present with ocular changes. So this is the typical presentation of West Nile virus chororetinopathy. And you can see here from these papers that we have West Nile in Brazil. So in 2013 and 2015 were published some papers showing that we have this condition in Brazil. And we had in 2018 and 19 an outbreak in the northeast of Brazil, in Ceará, that people did some diagnosed West Nile virus disease. So what I intend to present more is a condition that is immersion in Brazil, is pandemic in Rio for the last 20 years, that is sporotrichosis. So we was used to believe that this condition was transmitted by contact with soil, basically with plants, but we now know that this is zoonotic transmission by the cat. So this is the feline sporotrichosis. You can see these lesions in the cat. And it's important to say that many houses that we have cats, the cats just go to the park and play with other cats and transmit the condition. And many owners of the cats believe that they fight in the parks, and sometimes they just leave the cat, and the cats just spread the disease to other cats. So this is the distribution of sporotrichosis in Rio from 1997 to 2007. You can see here is major, mainly in the Rio city. And this is the presentation of the condition in the skin. It's very common in the skin. So it's transmitted by the cat. You can see the lymph nodes, and this is kind of, you have the lesion in the skin and then spread from the lymph nodes. This is the fixed, it's called the fixed presentation. And since 2003, we have been studying this condition, and you publish in American Journal retinal granuloma. So when you have the disseminated disease, you can have intraocular lesions, but you also can have dacryocystitis and multifocal choroiditis. And if you think of an endemic like sporotrichosis in Rio and AIDS at the same time, you can have the disseminated disease, so you can see some multifocal choroiditis. Again, you can see here. Of course, you can do the diagnosis based only looking the lesion, but if you have the systemic diagnosis of sporotrichosis and a lesion in the choroid, you can think of choroiditis due to sporotrichosis. Very recently, we did the ICG in one case, and you can see from this image, hypocyanescent lesion that is in the choroid. You've been seeing many cases of bulbar involvement of sporotrichosis, like scleritis. And just this week was published by a friend, Andrea Arinello, in our group in Fiocruz, 120 cases, culture proven, that present with sporotrichosis. And you can see here this presentation of this conjunctivitis. It's important to say that many people think that Paris syndrome is much common in Bartonella infection, and actually we see much more cases in sporotrichosis. If you can think of, I've been seeing 2 or 3 cases of Bartonella with Paris syndrome and more than 100 cases of sporotrichosis. And again, in the skin, in the eyelids, and the conjunctiva, and there are some complications with chronic dacryocystitis and symblepharon. So this is a new condition that most of you have to pay attention, especially in Brazil and in states close to Rio de Janeiro. So those are the sequela. And I would like to thank you, Manfred. I met Manfred, I think, the first time in England, and then in Turkey. And when I called him to come to Brazil, and he was just straight ahead and said, "Oh, I'm going. I love Brazil. I've been Pantanal and Iguazu Falls and in Amazon. Thank you, Manfred, very much to be here, to be such a good friend. And this is an image of you speaking in the first meeting that I did in Rio back in 2012. And I can see here you're very happy to be there. And thank you very much.
Great, Andre. Now it's a pleasure to have a person that coming from Venezuela and Middle East, now in the United States, and represent a kind of global leader in uveites, in retina, in viral infections, in ophthalmology. Fernando Arevalo is no doubt one of the most important ophthalmologists in the world, and already with a bright past, has an even brighter future ahead of him. Fernando Arevalo has always time to teach, always time to be with patients and with friends. And he's now in the United States, but as I said in the opening, for us, Fernando Arevalo will always be also Venezuela and Latin America. Fernando, welcome.
Thank you, Rubens. I really appreciate the opportunity to be here in this extraordinary initiative to honor our friend Manfred Zierhut, and as well to be among so many friends and extraordinary speakers. I mean, I really enjoyed and learned a lot from Andre Khoury. His presentation was just wonderful, and I'm looking forward to the rest of the presentations today. So my job today is to speak about management of retinal detachment in viral retinitis. These are my financial disclosures, which have no relevance to this presentation. And let's talk a little bit about viral retinitis in general. It's a rare disease that implies involvement of herpes virus, a family of double-stranded DNA that is characterized by latency. And the causative viruses include herpes simplex virus, varicella zoster virus, herpes zoster virus, CMV, and possibly Epstein-Barr viruses. Let's talk about the most frequent ones. CMV retinitis is the first one. It's the most frequent ocular opportunistic infection in AIDS patients, and of course in patients that have profound immunosuppression, including a CD4 count of less than 50 cells per microliter. It used to occur in about 30% of AIDS patients before the combined antiretroviral therapy era. But now that we have antiretrovirals since 1996, the incidence has reduced significantly and is about less than 1% today. So the patients with CMV retinitis that we see are mostly not AIDS patients, but belong to a different population that also includes neonates and those with iatrogenic immunosuppression following organ transplantation, hematopoietic stem cell transplantation, malignancy, or receiving immunosuppressive agents for other causes. These are just examples of CMV retinitis, including a patient with necrotizing retinitis along the supratemporal arcade with superficial hemorrhages, another case with an optic nerve lesion, again, very edematous, necrotizing with hemorrhages, but they can be also very peripheral with a more granular appearance and a lot of scarring and atrophy of the retina as the active lesion progresses posteriorly towards the central part of the retina. When there is healed retinitis, it's not uncommon to see microholes develop between the healed retina and the normal retina, and that leads to the development of rhegmatogenous retinal detachment. This is another example, supratemporal and temporal to the fovea, necrotizing retinitis that on the fluorescein angiogram, we can see that it's hyper and hypofluorescence. The OCT is useful to make the diagnosis of retinal detachment in many of these cases, which are difficult to see with the indirect ophthalmoscope because of the atrophy of the retina, and also can help make the diagnosis of exudative retinal detachments. The protocol to treat CMV retinitis includes antivirals systemically. It could be intravenously with ganciclovir or orally with valganciclovir, and intravitreal injections with ganciclovir or foscarnet at the dosages that you can see here on the slide. These are examples of patients with lesions supranasal in the right eye. The left eye was affected supratemporally. And on the bottom photographs, you see after antiviral therapy, complete resolution of the lesions. In terms of retinal detachment, it develops in about 20% of patients with CMV retinitis. Now, the current rate, fortunately, has been reduced by improved therapies for CMV retinitis, and of course, the immune status of our patients that has increased. And the number of new patients acquiring CMV retinitis has then fallen, resulting in a lower incidence of these detachments. Also, if we have a new lesion, it's important to treat early because the extent of retinitis and activity are risk factors for the development of retinal detachment. And if we have one retinal detachment, then we have to think about longer patient survival nowadays. We need to select surgical strategies that will improve the best long-term visual outcome. Vitrectomy with silicone oil and plant silicone oil removal, the use of endolaser is the mainstay of therapy. And we have to think ahead and long-term again, phaco plus IOL for cataract surgery and silicone oil removal later on may be needed. Again, the mainstay is vitrectomy plus laser and silicone oil. And this is another case where there was a retinal detachment, biopsy was needed to make the diagnosis of the etiology, and the insert shows here the inclusion cytoplasmic bodies that make the diagnosis of cytomegalovirus retinitis. And here is a surgical video that shows an implant of ganciclovir placed in a patient that had a retinal detachment due to CMV retinitis and was repaired at the same time. I don't have time to show the whole video. Samples for PCR are taken as well when the diagnosis is in doubt, and we can take a small sample of the anterior chamber with a paracentesis or vitreous biopsy or tissue of the retina, and very small samples are needed to make the diagnosis. Now let's turn to acute retinal necrosis. It's a clinical entity of progressive necrotizing retinitis caused by herpes simplex virus or varicella zoster virus. In young patients, it's typically caused by herpes simplex virus 2, but in older adults, it tends to occur because of varicella zoster virus or herpes simplex virus 1. Immunocompetence has been the hallmark traditionally of acute retinal necrosis. However, recent studies have shown immune dysfunction due to medications, malignancy, and other systemic disorders in up to 50% of the cases. We have to keep in mind that there is severe inflammation in these cases, as opposed to what we see with CMV retinitis. There is a lot of inflammation in acute retinal necrosis, and this can cause destruction of the tissues such as the retina and optic nerve, and we have to treat with anti-inflammatory medications combined with antiviral treatment to prevent visual loss and protect the fellow eye. This is a protocol to treat acute retinal necrosis. We treat with antivirals, acyclovir or valacyclovir, anti-inflammatory medications such as prednisolone, and intravitreal antivirals, foscarnet in this case, and topical medications. And the dosages will depend on the etiology. For herpes simplex virus related acute retinal necrosis, the low dosages are a little lower, and for varicella zoster virus related acute retinal necrosis, the doses are a little higher. You always start my patients on higher doses, and once I have the PCR result, and if it's herpes simplex virus, I just lower the dose a little bit. So these are examples that show the lesions in the periphery, a little bit more examples showing the lesions and dead cells that are just spread of the infection towards the posterior pole. Another example showing on the top photograph the activity of the lesion and then healed retinitis after therapy. Another case shows the peripheral lesions in 360 degrees, which is typical with some posterior pole involvement. In terms of retinal detachment and acute retinal necrosis, it occurs very frequently. Up to 75% of untreated eyes develop it usually within 1 to 2 months following the onset of acute retinal necrosis symptoms. Vitreous inflammation can lead to vitreous organization and PVR with subsequent tractional retinal detachment. I'm a big proponent of prophylactic vitreous surgery because most of these cases will develop a retinal detachment. And I do it when a patient does not respond well to proper therapy or if it is a fellow eye. But of course, if there is a retinal detachment, vitreous surgery has been recognized as the procedure of choice, and it should be done with silicone oil and endolaser. We have seen dramatic response of the necrotic lesions immediately after the vitreous surgery. Reports of the vitreous fluid obtained from patients with ARN indicate the presence of inflammatory cytokines, suggesting that the removal of these inflammatory cytokines induces a remission of these retinal lesions. That's why prophylactic vitrectomy is really useful. Silicone oil tamponade is ideal for retinal detachment with endolaser photocoagulation. So in summary, silicone oil surgery with silicone oil removal, thinking about combining it with phacoemulsification plus IOL implantation in patients with viral retinitis that don't respond to medical therapy and develop a retinal detachment is the mainstay of therapy. Other options could include vitrectomy with gas tamponade, sclerobuccal, or laser demarcation. As in the repair of any retinal detachment, surgical success requires permanent closure of retinal holes and relaxation of vitreous traction that may cause new tears. Planar vitrectomy with silicone oil injection obviously accomplishes these objectives, and if good adhesion is achieved, oil removal can be considered at a later date combined with phaco and IOL implantation. Finally, I'd like to invite you all to our Pan-American Congress of Ophthalmology in 2023 from 17th to 20th of March in La Rural in Buenos Aires, Argentina. You should come and get together. This will be the meeting that you cannot miss to reunite everyone after this pandemic. And again, I'd like to thank Rubens for the kind invitation, the opportunity to be here to honor our dear friend, Manfred Zierhut. Manfred has been a friend and a role model over the years. He has taught us so much about inflammation and uveitis, has taught us about how to teach because he's an amazing teacher as well, but has taught us so much about life. Manfred, thank you for your friendship and thank you for everything you do. We're looking forward to a lot more of your adventures. Thank you so much, guys.
Thank you so much, Fernando. And we are now over 120 people attending this. And I believe that, of course, the pandemic has brought tremendous loss, but trying to get the best from the worst. The new situation we have in the world has opened up new opportunities. And I feel good when I see a meeting like that, over 120 people, different parts of the different countries, and having no support from the industry. Of course, we all love money, we need money, but it's even more important to know that we do not depend on them. And having programs 100% independent, 100% depending just on us, I find a good opportunity in this new time. And the next speaker is gonna, oh, and before I forget, around 10 o'clock, we're gonna have pictures of everybody. So around 10 o'clock, try to open up your windows and have your face instead of your names. And we then have another publication honoring Professor Zierhut. The next speaker is Claudio Silveira. We have all known Claudio Silveira for many years as one of the more important investigators in toxoplasmosis. Claudio Silveira is an amazing example of a person living outside of the university, outside a large city and able to identify what happens in medicine. Cláudio Silveira is now a professor, has now a PhD, but he started just being an ophthalmologist, and coming from outside, coming from the field, he now has the rank of being a real great professor. Cláudio Silveira has always been ahead of me and ahead of many people. I remember when we asked Bob Nussenblatt to come to Erechim, and Cláudio showed his ideas, his patience, and Bob was very impressed. Also, our many of other friends, especially Emmett, that also since the beginning was interested in knowing more about Erechim and toxoplasmosis, and visit Cláudio Silveira. And now Cláudio Silveira is gonna talk to us about toxoplasmose and COVID. Cláudio, I don't know if you're gonna plan to speak in Portuguese or in English. I had told you to speak in Portuguese, so go ahead, please. Teu som não tá ligado, Cláudio. Agora está.
Então.
Bom
dia a todos.
Tá dando um pouco de eco.
Obrigado ao professor Rubens pelo
microfones
convite para participar da homenagem ao professor Manfred. E as palavras do Rubens, muito obrigado. E é graças a ele que eu, aqui fora do centro de uma universidade, consegui fazer algum tipo de trabalho. Então, quando o Rubens me convidou, nós pensamos em falar sobre recidiva de toxoplasmose, que é um assunto que eu tenho familiaridade. E, por coincidência, eu tinha um trabalho já em andamento, um trabalho simples, mas sem pretensão de alguma publicação, mas eu tenho um amigo pessoal aí, que é o César Victor, e ele estava me ajudando a fazer um estudo. E eu tinha duas perguntas para o César. E aí essas perguntas é o que eu vou tentar responder com essa primeira parte aí do trabalho sobre COVID e toxoplasmose. Então, esse trabalho, apesar de ser um trabalho pequeno, ele é um trabalho importante e servirá talvez como um piloto para um trabalho maior num futuro não tão distante. Bom, o que nós temos aqui em relação à primeira parte? São os pacientes com toxoplasmose sistêmica ou ocular. É quem tem toxo e quem não tem. São dois tipos de pacientes. E o desfecho desse estudo é a gravidade do COVID-19. Então, essa ideia é porque nós temos uma visão como oftalmologista, muitas vezes, de que toxoplasmose, para nós, é um olho com uma lesão em que você usa pirmetamina e sulfa e controla a lesão. Ponto. E aí termina a toxoplasmose. Hoje tem vários trabalhos, tem um livro agora bem recente do Torre, que o Rubens me mandou, que fala sobre os trabalhos do Flerg, mostrando que a toxoplasmose é mais do que só uma lesão no olho e merece, talvez, uma abordagem mais sistêmica para entender o que pode acontecer. E aqui, essas duas perguntas, nós vamos tentar responder. E a segunda é que nós pensamos inicialmente que se os pacientes que têm recidiva com uma determinada frequência adquirirem COVID, vão ter mais. Por quê? Porque vai ter alterações do sistema imunológico, o paciente vai ficar debilitado e vai terminar aumentando o número de recidivas. Então, o desfecho dessa segunda pergunta é a recidiva. Seguinte. Esse primeiro gráfico é para mostrar a distribuição de sexo, feminino e masculino, só mostrando que é uniforme. Seguinte. E esse gráfico é interessante, é importante. Veja que a faixa etária de 21 a 30 anos é onde tem o maior número de pacientes. E é uma coisa que a gente sempre falou, pacientes em idade produtiva, tendo lesões, reativações e, às vezes, ficando cego numa época importante da sua vida. E isso que está mostrando essa curva por faixa etária. Seguinte. O N que nós trabalhamos agora são 172 pacientes. 136 com toxoplasmose, e desses nós tivemos 87 com COVID leve e 49 COVID moderada ou grave. E no outro grupo, o grupo sem toxoplasmose, o paciente nunca teve toxoplasmose, IgG negativo. Nesse grupo são 36 pacientes. 29 deles com Covid leve e 7 Covid moderada ou grave. Seguinte. No gráfico dá para ter uma ideia melhor do que significam esses números. Seguinte. Aqui nós podemos ver que nesse gráfico, onde a gente tem toxo positivo, o número de pacientes com doença moderada ou grave é maior. O percentual aqui é 36% e o anterior era menor. Nós vamos ver o seguinte, por favor. Aqui nós temos 36% no grupo com toxoplasmose e 19% no grupo com toxo negativo. Então, mostrando que é possível que tenha realmente uma interferência. Isso eu já tinha visto no trabalho do Flerg, que publicou isso no ano passado, mas, aparentemente, com essa ideia de que nós, oftalmologistas, tóxico é só uma lesãozinha dentro do olho, a tóxico não teria uma repercussão sistêmica. Mas aqui, nessa comparação, dá para ver a diferença. Seguinte. Então, a conclusão é que os pacientes infectados com toxoplasma gondii têm uma chance maior de desenvolver sintomas mais graves de Covid-19. Seguinte. Esse é o trabalho do Flerg, onde ele fala que a toxoplasmose é um fator de risco para adquirir infecção por SARS-CoV-2 e um curso grave de Covid-19 na população tchecoslovaca. Esse estudo dele é um estudo pela internet. Seguinte. E ele também fala depois que, atualmente, a toxoplasmose não é considerada um fator de risco para a Covid-19. E os indivíduos infectados pelo toxoplasma não são informados sobre o seu maior risco, nem priorizados nos programas de vacinação. E como a toxoplasmose afeta um grande segmento da população humana, o impacto e os efeitos associados ao Covid-19 na saúde pública pode ser considerável. Seguinte. Segunda pergunta que nós vamos tentar responder é o número de recidivas. Esse é um trabalho antigo, na época que nós fizemos sobre trimetoprim e sulfentoxazol. Esse trabalho também envolveu a parte da epidemiologia, foi feita aqui pelo César Victor, que está de novo nos auxiliando nesse trabalho atual. Seguinte. Aqui é o gráfico. Dessa época, nós tínhamos um grupo que tomava sulfametoxazol, trimetoprim, e desse grupo, 8% dos pacientes tiveram recidiva, e o grupo controle foi 23%. Então, esse 23%, para nós, seguinte, vai ser o número que a gente vai considerar para comparar com os nossos atuais. Porque, na verdade, a ideia inicial era ter um grupo controle, pareado por sexo, idade, procedência, e isso está em andamento ainda, essa parte. Então, como nós não temos esse dado, nós vamos usar o grupo histórico, que é na época do Bactrim, que era o 23%. Dos 96 pacientes com Covid, 19 tiveram recidiva nesse período de 2 anos. Enquanto que, se nós compararmos com outro grupo, é 23. Seguinte. Então, no gráfico, a gente já consegue ver, é mais fácil de entender, sempre que nós tivermos Covid, nós vamos ter mais complicações. Seguinte. E o que aconteceu? Os pacientes com toxoplasmose que tiveram Covid não tiveram mais recidiva, diferente do que nós imaginávamos. Esses pacientes tiveram talvez o mesmo número, ou talvez até um pouco menos do que o grupo controle. Mas tem um detalhe, que é o seguinte: esses pacientes aqueles que tiveram recidiva, tiveram algumas recidivas graves. E talvez essas recidivas estejam relacionadas ao Covid. Nós vamos mostrar um caso sobre isso. Seguinte. Então, o caso que nós estamos mostrando é de um paciente de 61 anos, sexo masculino. Ele adquiriu, no mesmo mês, em dezembro de 2020, ele adquiriu toxoplasmose. Ele tinha um IgM de 22 para um cutoff de 0,60 e um IgG positivo. E em dezembro de 2020, ele também adquiriu Covid, um Covid grave, severo. Então, ele foi tratado durante 10 meses e não teve muita melhora. O que acontece? Normalmente, um paciente com doença adquirida pode fazer lesão ocular, nós sabemos. Isso é uma coisa que antigamente, na década de 70, não existia. Aí, depois de alguns trabalhos nossos, e com a ajuda do Miguel Burnier, depois que ele identificou irmãos não gêmeos, isso passou a ser rotineiro, mas não era assim. Então, essa ideia de que tóxico adquirida causa lesão, agora todo mundo sabe, mas passamos por um tempo para poder aceitar isso. E esse paciente tóxico adquirida fez lesão ocular importante, e nós vamos ver. Ele consultou pela primeira vez o nosso serviço já em 26/10/21. Ele tinha opacidades vítreas importantes, a visão era light perception, tinha só percepção luminosa e dava para ver apenas um reflexo no fundo do olho avermelhado. Seguinte. Aqui dá para ver pré-tratamento, né? Acuidade visual, percepção luminosa, light perception. Com boa imaginação, dá para se pensar que poderia ter um nervo óptico no fundo do olho e uma lesão, talvez, aqui. Então, por essas opacidades, talvez, essa visão de percepção luminosa. Esse paciente foi tratado, e após o tratamento, em 35 dias depois, dia 2/12/21, ele já apresentava, o olho já estava diminuído as opacidades, a lesão já estava mais aparente, e a acuidade visual era de 0,8, 20 e 25, mostrando que a evolução foi uma boa evolução, tinha uma visão útil. Seguinte. Então, a conclusão. Os pacientes com Covid-19 e toxoplasmose devem ser tratados com cuidados especiais, devido ao risco de complicações graves. Esses pacientes talvez viesse a ter uma complicação irreversível se a gente não tivesse tido oportunidade de intervir. E não só nós encontramos outras publicações, como essa do Jornal Francês de Oftalmologia, uma publicação recente, eles relatam um caso de uma recidiva com buraco macular e descolamento de retina, 2 semanas após adquirir Covid. Seguinte. Então, isso mostra que a Covid pode levar a quadros graves de uveíte por toxoplasmose e merece esses tais cuidados especiais que a gente está falando. Enfim, só para lembrar, a observação do César, Vitor, para que a gente fizesse pareasse, se tivesse um grupo de controle pareado. Isso vai ser feito num futuro não muito distante. Mas só para lembrar, além do César Victor, tem um estatístico da Fiocruz, que é o Sérgio Mundes, que nos auxiliou com os gráficos e com a planilha Excel para que a gente fizesse esse trabalho. Como eu falei, é um trabalho piloto, um trabalho simples, mas tem algumas informações que nós achamos que são importantes. Muito obrigado.
Muito obrigado, Cláudio. As usual, Cláudio has the capacity of seeing usually things that people do not see. And we have, in these years, followed the original observations coming from Cláudio Silveira. When he started to understand and explain the role of acquired toxoplasmosis in ophthalmology, people did not really believe in him. And coming from Cláudio, information is always important. Thank you so much, Cláudio. We have now maybe time for 1 or 2 questions, and I wonder if somebody would like to make a comment. 2 people, please raise their hand or electronic ones. Let's maybe start with people that is not presenting, Luisa, and leave our questions for later. Is there any question coming from the attendants that would like to speak, to ask a question? Please go ahead and raise your hand. We have now over 130 people, and I'm not seeing hands. So go ahead, Luisa. Why don't you ask your short question, please?
Well, my short question for Cláudio and for all the other uveitis specialists. This is an ophthalmologist that I saw yesterday. She is 37 weeks pregnant, and she developed this toxo-acquired lesion. And my doubt is, should I indicate her to have the premature birth of the kid, or should I treat? She has a lymph node and she is toxo IgM positive.
When is the baby due?
She is 37 weeks. The baby is for 2 weeks from now.
What is the vision?
2015. Good vision,
Normal vision.
normal vision.
Christina, what would you do?
Always me. Okay. She's pregnant.
She is.
The baby is due in a few weeks.
Well, you treat the patient, so no. Pregnant 1, 2, 3, 4 months.
Yeah.
37 weeks.
Yeah,
pregnant.
I think that, okay, you cannot, you don't need the picture anymore, Luísa. Cláudio, então, essa é uma grávida, final de gravidez, com a lesão na retina, a visão está normal. Você trataria apenas a mulher grávida? Você indicaria para antecipar o parto? Essa é a pergunta da Heloísa.
Primeiro, eu tentaria ver se essa paciente tem algum risco de passar para o bebê.
IgG positivo antiga.
Não, eu trataria com rofamicina, que é uma droga que pode ser usada, e manteria esse tratamento. Claro, tem que retirar ela um pouco antes do parto, mas inicialmente trataria, enquanto não baixar a visão, eu trataria assim. Uma segunda opção poderia se usar alguma medicação periocular, que seria uma dose pequena, que teria talvez pouco risco para o paciente. Mas como a visão está boa, inicialmente o tratamento que eu faria seria com rofamicina.
Ela não tem IgG, IgM positivo, adquiriu agora, essa semana.
So with Rubens Belfort and a group including Manuel Diaz-Llopis from Spain, we published a series years ago of intravitreal clindamycin, and we had several pregnant patients in the series, and it worked beautifully. And we didn't have to give injections very often for these patients. Once a month even was enough in these pregnant patients. And it's a good option to avoid systemic therapy. And being so close to delivery, I would definitely think that the baby would benefit from those few weeks that are left from delivery and not stop it. I think I would give intravitreal injections of clindamycin.
But she's
Thank you.
IgM positive?
Yes, she just seroconverted right now, IgM positive. It's an acquired infection.
I go with Claudio, as I said. I think we have to treat, don't you think, Claudio?
Okay. This is an example of how often we disagree in uveitis. Great. Thank you very much. We have to go ahead. And the next presentation is going to be in sarcoidosis. And we have a young ophthalmologist from Brazil, Ana Luisa Biancardi, also from Fiocruz. Fiocruz, for you guys that are not from Brazil, it's the most important agents for medical research in the country. And it's based in Rio de Janeiro with many labs and centers spread out in Brazil. And it's very important to have André Cury and the young generation guys working in Fiocruz. Ana Luisa, por favor. Você está sem som, Ana.
Can you see?
Agora você está com som e a imagem está ótima.
So, okay, thank you for the opportunity to be here. I'll talk about sarcoidosis, and it is a multi-system inflammatory disease with unknown etiology, and it is characterized by the presence of no caseating epithelioid granuloma in the affected organs.
the lungs are the most commonly affected site, and 30 to 60% of patients develop a uveitis with granulomatous features. Ocular sarcoidosis can occur before the patients develop other systemic symptoms, so it is a challenge for the ophthalmologist. A 48-year-old male referred to Oswaldo Cruz Foundation, Bill Cruz, with painless visual loss for the past 30 days. In the review of systems, he informed fever, fatigue, dyspnea, and weight loss. He had visual acuity of 20/40 in the right eye and 20/25 in the left eye. Inflammation of the anterior chamber in both eyes, and intraocular pressure was normal. The fundus exam showed optic disc swelling in both eyes, and the fundus autofluorescence showed some lesions in the left eye. He had hyperfluorescent optic disc, predominantly in the left eye, and vitreous cells and optic disc edema, OCT. And the ICG exam showed hypofluorescent lesions in the right eye and in the left eye, predominantly in the left eye. The patient underwent laboratory tests and image exams, such as syphilis, HIV, serologies, and tuberculosis skin tests, and they were all negative, and the chest X-ray was normal, and the cranial CT was normal, brought by the patient from previous consultation in another institution. Based on the ICG findings, the patient underwent a chest CT that revealed bilateral hilar lymphadenopathy, and it was performed a biopsy that showed nauseating epithelioid granuloma, which was consistent with the diagnosis of sarcoidosis. So in 2009, it was published the first results of the International Workshop on Ocular Sarcoidosis based on clinical intraocular signs and laboratory investigations suggestive of ocular sarcoidosis, and 10 years later, it was published the revised criteria, and the alterations occurred predominantly in the systemic investigation. And they are important because they are useful in the absence of a biopsy. The intraocular clinical signs remained the same, and we can see some of them: iris nodules, and mutton fat KPs, vitreous haze, and snowbanks, candle box dripping, and focal phlebitis, and chorioretinal peripheral lesions. Laboratory investigations: the abnormal liver enzyme tests were excluded, and 4 new laboratory investigations were included. In comparison, the diagnostic criteria, the possible diagnosis was excluded, and based on the biopsy, the patient was classified as a definite ocular sarcoidosis. Another case, a 61-year-old female with painless ocular hyperemia for the past 15 days. In the review of system, she reported reddish, painful, tender lumps in the anterior chins and arthralgia. She had visual acuity of 20/40 in the right eye, and also 20/40 in the left eye, biomicroscopy with copal nodules in the right eye, and IOP of 24 and 21. The fundus exam revealed optic disc hyperemia in both eyes, and a hyperfluorescent optic disc in both eyes. She underwent laboratory tests and image exams, and she had a negative tuberculin test, lymphopenia, elevated serum ACE levels, and chest X-ray with reticular interstitial infiltrates. The chest CT showed enlarged right paratracheal lymph nodes. I don't have the image. And she had multiple chorioretinal peripheral lesions. So she had erythema nodoso, chest X-ray and chest CT alterations validated by the radiologist, and the infectology excluded tuberculosis. And based on these revised criteria, the patient had intraocular signs, couple nodules, chorioretinal peripheral lesions, and bilateral uveitis, and 2 systemic investigations, a negative tuberculin test and elevated serum ACE levels, and another 2 that were included in the revised criteria, the lymphopenia and parenchyma lung change. And based on these findings, the patient was classified as a probable ocular sarcoidosis. And the last one is a patient of 32-year-old female with progressive painless vision in both eyes. And she reported inflammation of the breast with a lesion surrounded by a erythematous skin associated with a palpable induration. She underwent a biopsy that showed an occasionating necrosizing granulomatous inflammation, which was consistent with diagnosis of sarcoidosis, and she was treated with corticosteroids. Her examination, ophthalmic examination, revealed visual acuity of 20/40 in the right eye and 20/100 in the left eye, and biomicroscopy and intraocular pressure were normal. The fundus autofluorescence revealed in the left eye a hyperautofluorescent area and hypoautofluorescent image that was consistent with old scar. The exam revealed hyperfluorescent lesions in both eyes, predominantly in the left side, and some of them were seen in the left eye. The OCT showed a subretinal fluid in the right eye, and the findings of OCT of the left eye showed was compatible with the diagnosis of a central serous chorioretinopathy. And the follow-up of the patient, because of the ophthalmic alterations, it was done the prednisolone tapering and the introduction of immunosuppressive drugs, but she had side effects, and after these alterations, this treatment, the patient reported a new inflammation of the breast. In this case, still is ongoing, and it is important to see that not all ocular manifestations of during after the diagnosis of sarcoidosis are in fact ocular sarcoidosis. In this case, the complications are related to the treatment of the patients. So, diagnosis and treatment options for ocular sarcoidosis have changed over time. The availability of exams and procedures, which differ according to medical care systems, can compromise the achievement of a definitive diagnosis. Immunomodulatory treatments should be evaluated to achieve longer efficacy and less side effects, and future studies are needed to find more sensitive biomarkers. Thank you.
Thank you so much. It's good to see that good tradition of the Federal University of Rio de Janeiro with Haroldo and ocular sarcoidosis is going ahead. Well, our next speaker is longtime friend, Cristóbal Couto. At the time he was starting in ophthalmology, came to Brazil. We were happy in having him, and also followed his growth all these years. And Cristobal also was very happy with this tribute to Manfred. And now he's going to talk about some of his experience in VKH. Cristobal, bienvenido. Couto, you have no sound. No sound, Couto. Cristobal. Cristobal. I don't see Cristobal here. I see. Cristobal.
Yes. Now.
Estaba dormindo. You are sleeping. Just wake up. Good morning.
Can you hear me now?
Yeah, perfect.
Wonderful.
Okay. What I'm going to present today is our experience with the EDI-OCT. VKH disease is a bilateral granulomatous uveitis that also involves extraocular organs, such as the auditory system, meninges, and skin. It affects most commonly pigmented races. This syndrome is probably the result of an autoimmune mechanism influenced by genetic factors. Okay, the revised diagnostic criteria for VKH disease consists of 5 sections as follows: no history of ocular trauma, no evidence suggestive of other ocular diseases, bilateral ocular involvement in early and late stage, neurological and auditory findings, and integumentary findings. As VKH primarily affects the choroid with subsequent involvement of the retinal pigment epithelium and outer retina, multiple imaging modalities have been used to study the change in the choroid in different phases of the disease. As you know, ultrasound was the first. We can see the choroidal thickness with the ultrasonography. However, it was very difficult in cases in chronic stages. ICG angiography seems to be a useful method to assess the choroidal inflammation. Many authors like Dr. Herbert showed us the presence of signs such as diffuse delayed choroidal perfusion, hypofluorescent dots, and fuzzy vessels. In our paper presented at ARVO, 40% of the patients in a convalescent stage showed diffuse delayed choroidal perfusion during the early phase and multiple hypofluorescent dots and fuzzy vascular pattern of large stromal vessels during the intermediate and late phase. The advent of enhanced deep imaging optical coherence tomography has allowed clinicians to study the qualitative and quantitative choroidal changes in VKH due to improved visualization of the outer retina and the choroidal layers. The subfoveal choroidal thickness has been shown to increase in acute stage of the disease and serve as a biomarker for the response to treatment, as you can see in the slide. In 2020, we published this paper with the excellent work of Dr. Soledad Ormaechea, one of our fellows. The aim of the study was to correlate changes in subfoveal choroidal thickness with the degree of anterior inflammatory activity in chronic VKH disease. Anterior segment inflammation was assessed using some anterior chamber cell grading criteria, and the subfoveal choroidal thickness was measured using EDI-OCT in patients with VKH at multiple visits. ANOVA was used to compare the mean subfoveal choroidal thickness for each anterior chamber cell grade. Regression analysis was used to correlate the anterior segment and the subfoveal choroidal thickness. 14 patients, 28 eyes were studied. Each patient had multiple follow-up visits. Anterior segment and OCT scans were analyzed for both eyes at every visit. The mean age was 44 years. More than 85% were females. The mean duration of the disease was 73 months. Time of follow-up with EDI OCT was 24 months. The mean subfoveal choroidal thickness corresponding to different grades of anterior chamber cells as assessed by Sun grading scale is shown in this table. ANOVA analysis demonstrated significant differences between the mean subfoveal choroidal thickness for different grades of anterior chamber cells. As you can see here, while patients with no plus cells have a normal choroidal thickness, those with 3 or 4 plus cells have an important choroidal thickness. In this figure, box and scatter plot shows the distribution of subfoveal choroidal thickness data for each side grade of anterior chamber cells, and also demonstrates the change in subfoveal choroidal thickness with an increase in the anterior segment inflammation. In conclusion, in chronic stage of VKH, choroidal thickness changes more dynamically with an increase in the anterior segment inflammatory activity. An increase in the anterior chamber inflammation is generally associated with a corresponding increase in the subfoveal choroidal thickness. This highlights the role of anterior segment inflammation as a potential biomarker for subfoveal choroidal thickness changes in chronic PKH. Thank you very much for your attention.
Thank you very much, Cristóbal. As I said in my opening, Emilio Dodds could not be here today. He's traveling by car, has no sign, and we are very happy with Couto representing Argentina. Great. Well,
is there a time for a question, Rubens?
Absolutely. You're always welcome, Fernando.
Thank you, Rubens. I like to treat my VKH patients with a combination of steroids and immunomodulatory therapy from the beginning. We have shown in the studies that with that long-term, we can decrease the chances of patients developing complications. We decrease the chronic stage, the convalescent stage of the patients, and with that, the complications. So I see you have presented quite a very beautiful paper on chronic VKH disease. How do you like to treat your patients from the beginning? Do you agree with combination therapy, or do you treat up with steroids alone?
No, I agree to treat the patients with combination. The combination therapy now is the main treatment in VKH patients.
Thank you, Cristóbal. Good to see you, my friend.
Thank you. Good to see you too.
Miguel?
Yes, I'm just going to make a comment.
Miguel is the first and also the youngest generation of the IUSG. Miguel is like a pathologist, see, always there.
Thank you, Rubens. I'm not going to make a comment. Hola, Cristóbal, ¿qué tal? ¿Bien?
Hola, ¿cómo estás?
Qué bueno. I'm not going to make a comment about Cristóbal's paper, but I'm going to make a comment about Eloisa's patient, because Claudio Silveira said something so important. Of course, the ocular manifestations of tox are so important, but tox is a systemic condition. And I was reflecting in Eloisa's comments, and perhaps I misunderstood, but if I understood correctly, patient present with IgM positivity and the lymph node, right? then I think patients should be treated systemically with the clindamycin because of the lymph node. This is a systemic disease, not only ocular.
Yes, I treated her systemically, but my main concern was with the baby because she has an acute toxoplasmosis with ocular lesion, and she is 37 weeks pregnant. So I was concerned if she got the infection now, maybe doing a premature parturition would remove the baby from this risk, or
Yeah,
we treat her systemically and
in a way
examine
2
the
weeks.
baby.
In a way 2 weeks, because in 1 more week the baby is completely at term. I would say you can get the baby out a week before the due date. By the way, gynecologists and obstetricians never ever get the due date right. Therefore, doesn't make any difference.
Mhm.
So
This is
what
a
I don't
she-
see,
this is a father.
ophthalmologist.
This is a father of many kids and many grandchildren. Speaking, Miguel once traveled from Canada to London just to see the birth of his grandchild, and stayed there for 2 weeks watching tennis games on TV. Okay, now we're gonna
yes, so
proceed.
Rubens, if you allow me just very quickly, we treat with clindamycin many times combining with systemic, but in this case, I would treat with intravitreal clindamycin, and as Miguel very rightly so alluded to, we can start systemic therapy after the baby is born. I mean, I agree with that completely. Sure.
And also, I'm sure that Eloisa asked for a complete workup of the fetus, ultrasound and many other imaging tests in the fetus can give you some hints of what may be going on, right? Let's proceed because we have many speakers in the program, and the next one is going to be Daniel Vitor Vasconcelos. He's going to be speaking multimodal imaging on infectious retinitis. Daniel trained with Narsin Rao and Fernando Refice, and is one of the leaders of the field now. And they're very happy with Daniel being here in this program. Daniel, go ahead, please. Daniel, sem som.
There you go.
Daniel?
So I'm sorry. Yes, can you hear me?
Go ahead. Yeah.
Okay,
If
so
you
sorry.
have-
Again, congratulations. Sorry.
Go ahead.
Oh, so thank you, Rubens, for the kind words. Congratulations for organizing this fantastic tribute to this unique human being who is Manfred. We will speak about imaging of infectious retinitis. When you look at infectious retinitis, we have to be careful because of this extensive list of differential diagnoses, which may be indeed complicated by concomitant HIV infection. As you all know, multimodal imaging has brought a revolution to the clinical approach of uveitis and of retina patients worldwide. And it does help us characterize much better what is happening, what's going on, and also help us monitor our patients. The approach is based on a combination of different imaging modalities, as you know, and I'm going to show several conditions and examples of the utility of multimodal imaging. So this is the first case of a 6-year-old boy with decreased vision in the right eye for 1 month. This vision was down to 2400. And if you look for an external picture, you see this whitish change in the infratemporal retina. The wide field imaging nicely shows this round reddish structure at the infratemporal peripheral retina, consistent with the toxocara granuloma. The kid was positive for IgG. The B scan also help us measure the size of the lesion. Then he was put on therapy. The vision improved to 20/80. Unfortunately, he was kept with some degree of macular edema, but there was definitely some improvement on this case. Toxo, of course, is our leading etiology of infectious posterior worldwide. And OCT nicely recapitulates what's happening in histology. You see this hyperreflective and change in the neurosensory retina, which is also accompanied by this fusiform thickening of the inflamed underlying choroid, recapitulating this retinal choroiditis pattern. You see in this case of a focal lesion adjacent to the disc, the same picture of focal necrotizing retinal choroiditis, as you can see. On the angiogram, the toxoplasmic lesion is typically hypofluorescent. And as the examination, as the transit of the dyes goes on, we see the progressive hyperfluorescence of the margins of the lesion. ICG is helpful to show us the choroidal change, the choroidal infiltration, which shows to be hypocyanescent. Also, if you see, we have OCT angiography, we see the flow void at the level of the underlying choroid. Imaging is also nice to document secretitial changes. This is a case of a child with congenital toxoplasmosis, where we see this colobomatous change at the level of the macula with complete absence of retinal layers at the level of the scars. Imaging is also helpful to show progressive improvement following therapy. We see the resolution of toxoplasmic lesions is usually centripetal, leaving a complete hypoautofluorescent scar. You see the progressive high autofluorescence changes along treatment. And on the OCT, you see the baseline, the follow-up showing how not only the retina, but how the choroid responds positively to antiparasitic and corticosteroid therapy. You see another case here, the progressive shrinking of the lesion, leaving a toxoplasmic scar. This is an interesting case of a patient, a lady she was treating for a thymoma on chemotherapy, and she developed a decreased vision in the right eye. She had multiple lesions at the peripheral retina as well as at the macula of her right eye on wide field imaging. As you can see, the fundus was hazy because of cataract. And on the angiogram, even though the pictures were quite hazy, we could see that the pattern was that of initially hypofluorescent lesion, which progressively hyperfluoresces in the late phases. This would be consistent with toxo, and we could get the OCT showing that hyperreflective disorganization of retinal layers accompanied by this fusiform thickening of the underlying cord. So this is highly suggestive of toxoplasmic retinal choroiditis. So she underwent an AC tap, but she was put on therapy because the results of AC tap take a while. And she ended up coming positive for Toxoplasma gondii, showing us that multimodal imaging was quite accurate for this presumptive diagnosis. For TB, this is an example of a 34-year-old patient with this lesion adjacent to the optic disc in a presumed picture of a neuroretinitis. However, if you look at the OCT, the primary lesion was sitting in the choroid, but not in the retina. So there's not a retinal neuroretinitis, but actually maybe a neurochoroiditis, if you can see that one. So she came up with a positive tuberculin skin test. She was treated and very nicely responded. Some other examples of TB, choroiditis. So the most common presentation of ocular tuberculosis is based on choroidal involvement. So you see this patient with multiple scars and also active lesions in the choroid of the left eye, leading to this exudative retinal detachment. As you can see, she was put on treatment for TB and very nicely responded. And last but not least, another case of patient with the so-called serpiginoid or serpiginous-like choroiditis associated with ocular tuberculosis, for which wide field image is quite useful to delineate the changes. A patient with a bilateral pan-uveitis, chest X-ray changes consistent with TB, strongly positive PPD. He was put on anti-P therapy. However, on D8, he developed this multiple pre-retinal and retinal infiltrate in his left eye, which were very highly concerning for a paradoxical reaction. He was then put on systemic steroids and very nicely responded, as you can see in these pictures. Syphilis is a reemergent disease. This is the typical placoid chorioretinitis changes associated with syphilis. You see also the OCT changes, this granular changes at the level of the RPE and the thickening of the choroid. if we have ICG available very frequently, we do see this placoid hypocyanescence at the level of the choroid in these patients. The so-called inner retinal infiltrates associated with syphilis that had been described as a quite distinctive and typical and suggestive changes associated with this entity. You see the retinols are located in the inner retina, but sometimes we may have yellowish changes at the peripheral retina, which may not represent indeed retinal infiltrates, but granulomatous precipitates sitting in surface of the retina or below the detached posterior hyaloid. As you see in this case, these nicely respond after therapy. Viral retinitis, CMV retinitis, wide field imaging is absolutely very useful to help us monitor these patients before and after therapy. As you see in this case, what happens in CMV is a complete destruction or atrophy of the retina because of necrosis, full thickness necrosis. And very interesting, we don't see much choroidal reaction because of severe immunosuppression in these patients. Acute retinal necrosis is also another condition that benefits from wide field imaging to document the progression and even response of these lesions. This patient eventually developed a rhegmatogenous retinal detachment inferiorly here, as we can see. Cat scratch disease, we have the typical picture of a neuroretinitis and sometimes associated with inner retinal infiltrates, which you can see in this picture. So this combination of neuroretinitis associated with multifocal retinitis is quite suggestive of Bartonella. So OCT shows that the inner retinal location of this infiltrates, which very nicely respond after therapy. Immunosuppressed patients as HIV positive ones may have this angiomatoid response with very high fluorescent lesions, which very nicely respond after specific therapy. This is an example of a patient we had recently. He was admitted to the hospital with fever of undetermined origin. He developed decreased vision in the right eye, and he had a granulomatous lesion from a cat scratch close to his left thumb. And what was interesting was that in the contralateral eye, he had two inner retinal infiltrates that were documented here in OCT. This was pure retinitis, but this was more of a retinal choroiditis with an angiomatoid pattern, as you see in OCT. And he also very nicely responded to specific therapy. This is another young lady with fever of undetermined origin and acute abdomen. She ended up undergoing exploratory video laparoscopy, which revealed nodules at the level of the spleen and of the liver. And she came up for ophthalmic examination in which we saw this pattern of multifocal retinitis. She had also multiple scratches in her forearms, and this made a diagnosis combined with serology of Bartonella multifocal retinitis. You see the level of the infiltrates here. Patients with migratory infiltrates in the retina, in the outer retina, as you see in this patient, we have to look at the lesions which look more recent, as in the upper periphery here you see. And on a close-up, we see the S-shaped larvae, and we could very nicely get the OCT showing the outer retinal location of the cross-section larvae just below the ellipsoid layer. And last but not least, a patient with Candida endophthalmitis, in which we see the OCT showing the specific focus in which the fungus goes from the retina and choroid to the vitreous body. She was treated and very nicely responded to therapy. So in conclusion, infection should be ruled out in any retinitis. There is, as you all know, a wide range of diagnostic possibilities, but multimodal imaging is definitely useful to help us clarify these nuances of diagnostic patterns. Just to finalize, I like to say that I bore this image of the rainbow mountain from Manfred. This was his idea. He's a person that definitely sees much further than we normal human beings do. And I just want to tell you a very short story. Many years ago, when I was in Los Angeles, we had Manfred for a few days, and we had a very nice dinner at a Mexican restaurant. At the time, we were talking about several issues, including music. And as you know, I'm from Minas Gerais, which is is where Milton Nascimento was born. So I sent his message saying, you know what, maybe one day you can come up to appreciate the mountain sea of our dear Milton Nascimento. And many years later, he came up to Belo Horizonte exactly a day in which we had a concert celebrating the 50th anniversary of the Clube da Esquina, which is the music group the music movement led by Milton Nascimento. And by, I think, a coincidence, we went to the backstage, and there was him, Milton Nascimento. We had a few seconds with him. That was really, I think, that the most fantastic experience I had with Manfred himself. So thank you very much, Manfred, for all your generosity, for inspiring so many human beings, so many ophthalmologists all over the world. Danke.
Great talk, great talk.
Thanks so much.
Excellent. There are many things to talk about, Manfred, of course. And I'd say that one of the most important is related to the work he has done regarding publications. And he really made the Journal of the IUSG one of the really important ones. And now having Derek Smith, that is also here today, present with him, brings even more importance. So congratulations also for that, Manfred. Your work as editor is something very, very special. We have now a few minutes for questions and discussions before we go to the next presentation. I wonder if there is any question or comment. I see also Emmett Cunningham here. Emmett also is a constant presence among investigators and students from many, many countries. And he also has a global view that is so important in meetings and organizations like the IUSG. Is there any questions or comments? Please raise your real hand or electronic one.
Can I have a short question about the sarcoid presentation, which was very nice? I think I also was part of these workshops, and it seems that we always have to follow the pulmonologists. The updated situation of the pulmonologist is that the highest certainty you can get for sarcoid in contrast to tuberculosis ER is B-HeLa lymphadenopathy. It seems that even a negative biopsy does not prove anymore that this is not tuberculosis. So we will see. I think this is already part of the rules for the pulmonologists. The highest degree certainty you can get for sarcoid B-HeLa lymphadenopathy, no biopsy anymore. I think we have to discuss this with the group if we have to change anything in the criteria in the near future.
Thank you, Professor. Very good to remember this thing.
Rubens.
Miguel, go ahead.
Manfred was so right. I think we have to discuss also another issue, which is the following. Because the hilar lymph nodes, sometimes you may see tuberculosis doesn't show the huge area of casus necrosis. And remember, sarcoid is always diagnosis of exclusion because it's a non-caseating granuloma. There's one ocular manifestation that's almost exclusively of sarcoidosis, particularly in African Americans in North America, which is a bilateral involvement of lacrimal gland. Symmetrical, bilateral, you make a diagnosis with a CT or MRI, and if you do a biopsy, it's much more positive than conjunctiva. Tuberculosis never does that. Then bilateral symmetrical involvement of lacrimal gland is very characteristic of sarcoidosis. And Anna said something so important. The pulmonary activity, the pulmonary function tests are also extremely important in the absence of a biopsy.
Thank you.
Any other comment? Manfred, what would be your first treatment for bilateral diffuse uveitis consistent with the diagnosis of sarcoidosis?
Well, if you're more or less sure that this is sarcoidosis, I definitely would do all the TB tests and things like that. We are not living here, at least in our parts, in any endemic area. Definitely high-dose steroids. I'm very sure about this one. There's nothing as effective as high-dose steroids. And then you will have to see. I think another very important point with sarcoidosis is there any relation to the lungs or not? And you should not wait for too much involvement in the lungs. I think there is another similarity between TB and sarcoidosis. We know from Vishali's studies and the whole group there that ocular TB is 80% outside of the lungs. So that's another thing which I really would love to continue working now to bring together these specialists from lung tuberculosis and sarcoidosis so that they better understand our situation. Yes, in the worst case, if ophthalmologists are not able to treat systemically with high dose of, it may be steroids, immunosuppressors, something like this, this may be blocked by systemic specialists, and this is not acceptable, I think. So we have to be a little bit more self-confident in this regard. We know such a lot about these diseases and we know how to handle them. So I think that's another very important role for something like an international group like the IUSG, and we are working on that one.
Excellent. You have done that regarding Bechet many years ago when you had this fantastic meeting with non-ophthalmologists, experts in Bechet, and we all learned a lot, right?
These were the ETAL meetings, yes. Unfortunately, I think, let's say simply, this takes a lot of preparation, time and money, such meetings. And after taking over the job of editor-in-chief of OII, that was a really problem to reestablish this one. I'm not sure that I can do that again. But the idea of this one also is to bring together ophthalmologists with basic scientists, probably Bechet people, rheumatologists, immunologists, and things like that, and then to discuss. And then something which I'm missing in a lot of meetings is the idea of ETAL was probably 20–30% of presentations and 70% of discussion. So the presentations were the introduction of people which are not absolutely aware of what's going on in, let's say, ocular Bechet's disease, to understand our problems, and from that to build up the basis to discuss. I think these are very important things, yes. We should go on with these things.
And you have done it also in Israel a few years ago when we had a meeting with a lot of discussion, and we have to go to the meeting to learn and not only go there, give the slides, pretend you are teaching and leave, right? And
well,
that's important.
This was the guidelines for the diagnosis of vitreoretinal lymphoma. This was a hell of a work, of a process of approximately 1 year. And in the conclusion, the last questions which were not, didn't find supportive agreement under the people, this is what we discussed then finally in Tel Aviv in a one-day meeting on a Delphi procedure. And again, this is also something I think such societies like the IUSG should do. And but you see the limitations. I think it's fine to do that with diagnostic of vitreoretinal lymphoma, but what about treatment of vitreoretinal lymphoma? Here you reach much more other societies, and it's much more complicated to find a consensus for this one. So this is, I think, years in front of us to find a consensus for treatment of vitreoretinal lymphoma. Yeah. But this is, again, I think it's absolutely necessary. And we also plan to do something like this for the coming meeting in Utrecht. And I have a chance, I discussed that with Eloisa, to talk probably 7–8 minutes at the end. And I will bring this project, which was planned already. It's a very simple thing, I think. was planned for Singapore, we will take it again. We take it up again in Utrecht.
Great. Well, as I said earlier, we're going to now have a picture of everybody. So if you could please activate your images and they'll have a chance to have all. I see Manta Agahau here. Hi, Manta. You are part of the family also. Great to have you here. Alejandra,
Great
so
to
many
have you
people. Great. Derek Smith already mentioned, excellent to have you aboard from South Africa and from the journal. Derek plays a very important role in science. Great. Okay, I believe that now everybody is activating their images and okay, guys, check your hair, check your face, check your maquillage if you are wearing it, men and women, and go ahead. Okay.
Just a minute, please. Okay. Just a minute, Dr. Rubens.
Okay, somebody's finishing the maquillage, okay? Great. Justin here too. Hi, Justin. Great. Okay. Our photographer, I don't know, our technician, I don't know, somebody's taking the picture. I hope it's gonna work. In the meantime, I want to introduce our next speaker, Juliana Orefice. It's impossible to have anything in uveites without mention the name of Orefice. And even more important, now we have 2 generations of Orefs. And Juliana, please do not share your image yet, because we're gonna need to have all the people in the picture. Could you please? Okay, great. Okay, wait. So I was saying that it's very important. It's very nice to have 2 generations of Orefice now working uveites, Fernando and Juliana, and having to decide who to invite. Of course, Juliana is the one. She's a woman. She's beautiful. She's bright, and more than that, I'm sure that Fernando is proud and happy in having Juliana representing the family here. So wait a little more, Juliana. Ricardo, did you take the pictures?
Yes.
All of them?
Yes, I do.
Okay, we have 133 people already here, Manfred. So now, Juliana, please go ahead. Thank you so much for having accepted. And Juliana is going to discuss choroiditis.
Thank you, Dr. Rubens, for
Juliana, your slide is now perfect. Thank you.
Now?
It's perfect. Okay. No?
Perfect. Okay.
Okay, now it's perfect. No?
It's an honor to be a part of this tribute to Dr. Manfred and to able to share my experience in multimodal image and choroiditis. It's a heterogeneous groups of ocular autoimmune disease primarily affect the chorioretinal interface. The clinical presentation is uni or bilateral, sudden, insidious, acute, recurrent, chronic course. Some have a high spontaneous resolution, whereas others is a serious risk of visual loss and require aggressive immunosuppressive therapy. Consequently, it's critical to distinguish these disorders from another. This is our area of interest, the choroidal retinal interface. The purpose of retina and choroidal imaging is to make the proper diagnosis, or at least reduce the difference diagnosis. Multimodal image has been shown more sensitive than any single image modality in detecting retinal changes and can be particularly helpful in those white spot syndrome that cannot be easily distinguished on clinical grounds exam alone. We can classify this disease in limited, recurrent, or chronic. The recurrent and chronic may be treatment. I chose 3 diseases in which multimodal image has helped our patients. Non-infectious choroiditis, we have to study clinical finds and angiography finds. These are fundamentally. With the advent of SDD, OCT, we start using multimodal image, and we use the fundus autofluorescence when the hypoautofluorescence is the damage of photoreceptor, and hyper, its RPE function is compromised without photoreceptor genes. We have STD, OCT, spectral OCT, EDI, OCTI, and near-infrared autofluorescence, with in vivo evaluation of RPE and choriocapillaris melanin. It's important to remember that exams is invasive exams. Acute posterior multifocal placoid pigment epitheliopathia. It's very important in know that in the hair care case, it's associated with cerebral vasculitis. Clinical finds is bilateral disease, asymmetric young patients preceded by a full field leak episode. ICG, you have a hypofluorescence, and the fluorescence, you have hypo in the early and staining in the later. Fundus autofluorescence, we have hyper in activic, acute, and people with have severity affect areas. In SED and DI and OCTA, we have choriocapillaris dropout. In the first case, it's a woman or a man in decreased vision in right eye for 3 days after 1 week of influenza-like itis. In right eye, 20/20/50, and the left eye, 20/32. We see multiple green white placoid pole, more in number and involve the fovea area in the eye. Now it's a multimodal image, and you can see in the near infrared autofluorescent areas with hypoautofluorescence. In the fundus autofluorescence, you have show hyperreflective, hyperautofluorescence. The UCTA, you know, choriocapillar grows up. After 2 weeks, we see the hyperautofluorescent in fundus autofluorescence, and in the UCT, you can see this find with Goldberg, it's stage 1, when we have thinning of the ellipsoid zone, disruption of stem-limited membrane, and separation of ellipsoid zone and RPE. It's very important to see the hyperreflective on outer nuclear layer. This is the baseline In stage 2, 2 weeks, decrease the reflectivity in the outer nuclear layer and thinning of the outer retinal layers. In stage 3, 4 weeks, you have the ellipsoid junction almost entirely regard in normal appearance and minimal persistence irregularity in the RPE. Now, in the follow-up, using the fundus autofluorescence, we can see the changes and more specifically, the choriocapillaries. The second disease is a multifocal choroiditis pan-uveitis hypointake interchoroidopathy. It is a study of Spacey, Dr. Spacey, and he find the same finds in the two disease. I show you a case with the female, decrease the vision in the right eye for 3 days. This is the right eye and the left eye. You can see the multimodal image and you see the hyper autofluorescence in the near infrared autofluorescence and here in the other eyes. When ICG, we see the choroidal neovascularization. The same in the fluorescent angiography. And the UCT, you can see the choroidal neovascularization. And the follow-up after oral steroid and 4 seasons of anti-VEGF therapy. You can see the involution process of the CNV enveloped by the RPE. And the patient returned with worsening vision. And you can see now this hyper autofluorescence, ring shape hyper auto on near infra autofluorescence, and in the autofluorescence may indicate the involutional process of CNA enveloped by RPE. Now you see the baseline after the treatment, and now there is a new lesion. The ICG show the new lesion. And so this is the baseline after the anti-VEGF treatment. And now you show the attenuation of ellipsoid zone, the deeper penetration of SD-OCT signs, and those shapes of RPE elevation. Now the new lesion, you can see the down-shaped sub-RPE and the subretinal infiltration. Here, the homogeneous medium reflective material extending into subretinal space. Finally, I could not fail to mention the contribution of fundus autofluorescence in the follow-up of serpiginous choroiditis. This is the clinical finds, ICG, and now the autofluorescence. In the active phase, we have hyperauto and hyperauto in the RPE atrophy. OCT, you see the shape of RPE. And now this is the follow-up using the multimodal image when The stage 1, you have hyperautofluorescence. And the stage 2, predominant hyperauto. And stage 3, ring shape hypoautofluorescence. Thank you.
Hello, can you hear me?
Yes.
Okay, I thought I had I was died. Great, Juliana. Thank you so much. Thank you so much. We now go to the next presentation, and after that, we're going to have some time for discussion. Lourdes Arellana has been here since the beginning. Lourdes, thank you so much for coming here. You are also an example for what can be done in Latin America and what you've been doing in Mexico. Go ahead, Lourdes, please.
Thank you, Rubens. Hi, Manfred. Thank you,
Hello.
Eloisa. Well, I will present a short talk about something that makes me very curious. I don't know why I cannot change my slide. Can somebody help me? Okay, thank you. Okay, we all know that fuchs is an anterior chronic low-grade, frequently unilateral uveitis with diffusely scattered stellate KPs, iris stromal atrophy with or without heterochromia, and vitreous cells and debris. Diagnosis is based on typical clinical findings. Next. Several theories about why inflammation is triggered have been proposed during much time, but until now we are not sure about any of those theories. Next. Although fuchs has been classified as an anterior uveitis, besides vitritis, other posterior pole findings have been described. Next. Iris pigmented epithelium and choroid share the same embryologic origin and the same irrigation. Next. So maybe influx inflammation can involve both iris and choroid. Next. In fuchs patients, iris and choroidal thickness reduction has been previously described. Most authors suggest that chronic inflammation may affect tissue perfusion, leading to ischemia, reduction of thickness, and atrophy. Next. Next. So I will present you the case of a 38-year-old male that complains of progressive decrease of visual acuity, OD. Next. Next, please. Anterior segment findings are very suggestive of a fuchs diagnosis. Next. And the posterior pole findings were irrelevant. Next, please. Next. Next. Okay. So fuchs uveitis syndrome diagnosis was made. In this case, we decide to measure iris thickness following the technique described by Ibernisi et al. Next. And we found out that in the affected eye, iris was thinner than in the normal eye. We also measured the iris choroidal thickness, subfoveal choroidal thickness, following the technique described by Spade. And also, we found that in the affected eye, choroid was thinner than in the normal eye. Next. So please go back one slide. So Fuchs, we know that Fuchs is clinically different from other uveitis, that it is refractory to corticosteroid treatment that is chronic and low grade. Our case shows that Fuchs affects iris and choroid. So is it a panuveitis? Iris and choroidal decreased thickness may be caused by low perfusion secondary to chronic inflammation. Next. In this case, we found thinner iris and choroid in the affected eye. Chronic anterior chamber, vitreous, retina, and choroid inflammation may lead to changes in iris and choroidal perfusion, which may result in tissue atrophy. Imagine evaluation of more cases will confirm these findings. Next. But until now, we don't know what triggers inflammation. Thank you.
Excellent, Lourdes. And of course, we all know that Fuchs is a kind of entity that was diagnosed over 100 years ago. And many, many theories, and probably we do have many etiologies, right? Not necessarily infectious, and something that we're gonna be keeping in discussion, I believe, for many, many years. We have now time for maybe one or two questions. I wonder if somebody would like to ask or make a comment. Please raise your hands or speak up. I would like to say that many, many decades ago, we described the association between toxoplasmosis and Fuchs. At that time, there was no information about the role of rubella and Fuchs, and probably this study would have to be done again in order to avoid the possibility of confusion of the data that we studied at that time. Is there any question about that? I don't know if guys from other countries would like to comment on that. If not, we're gonna proceed and
I just wanted to make a comment, Rubens, on
yes, please,
the
Fernando.
presentations from Daniel Vasconcelos and Juliana Orefice were just fantastic. They showed something that I believe very much on multimodal imaging and the pattern recognition of lesions on infectious retinitis or conditions and non-infectious conditions. I think that we should all familiarize ourselves with the images and on not only clinically, but with all the different options of imaging that we have. And that is going to help us make the diagnosis more readily. I thought those presentations are really key, and I'm happy to be here and learning from all of you guys.
Excellent. It's a big point. Imaging is already essential, right, Fernando? And it's going to be more and more. I hated to talk and give the impression that I'm just doing advertisement, but this new camera, the California, that also does OCT on the periphery of the retina, and I find it fantastic. You are able, using multimodal imaging, to image the retina and at the same time have OCT of the far periphery. And very often we see things that we never imagined they would be there. Do you have any experience with this equipment, Fernando?
Yes, it's very useful, absolutely. And it allows us to visualize. I have used it for many retinal conditions, not for uveitis as much, but for many retinal conditions, allows us to see peripheral lesions that can help us in the diagnosis as well. And documentation, I think, is a beautiful, beautiful machine. And again, I agree with you. We're not advertising. We're just enjoying the opportunity to get more information to help our patients. I think we have to image our patients and be able to help them make a diagnosis, more proper diagnosis, and treat, which is the main goal, to help them.
Yeah, and when I have to declare my financial interests, I used to say that they don't pay me, I pay them.
Exactly.
And very often they hate me. Especially when I talk about Ozurdex, they hate me. Okay, any other question?
Yeah, can I ask one question here? Have anybody seen this with COVID infection, the retinitis? It was amazing presentation, Daniel. But I was just wondering, do you worry about it? Have anybody seen in COVID infection, post-COVID, any retinitis? Because virus, what we are talking about.
Great question. Would somebody like to answer that?
No.
What's your own experience about that?
I don't know. I just keep it as a differential, but I've seen a patient where the antibodies were high, where the patient just said he doesn't have any history. But are we worried in this pandemic that have we really seen any retinitis?
What I have seen is VKH, and we think that probably COVID can trigger inflammation on patients that are predisposed for other reasons. And other retinitis I have not seen. There are many publications on this, however, and it's possible that COVID changes the immune system, and then we can have triggering of these inflammatory conditions.
Yeah, we've also seen the herpes infection reactivation, actually, seen, but per se, COVID virus, COVID-19 causing this, we haven't seen, right?
Luciana Finamore, I believe, is here. Luciana works with us, and she has really followed what happened, what goes on, and she has tried to make association between COVID and toxoplasmosis. And so it's very interesting to see Claudio Silveira also discussing that. Manta, I fully agree with you, and I've been trying to see, for instance, if our patients bitch it and have a worsening of the clinical picture because of COVID. We know that the vascular changes of COVID, vascular changes may be associated even with immunization. And so far, I have not. But I think it's very important that we keep looking at it. And this would be another very interesting point to hold maybe a discussion, scientific program, listen to a specific experience. And this is another role of the IUSG, I believe, promote virtual forums to discuss a specific aspects. Great comment. Any other question?
Short comment to this one. I think retinitis is a pure, more or less pure infectious disease. I guess that there is some COVID-19 in the retina, but this is not sufficient, I think, to start an infectious process. What we see in COVID are more or less immune processes. We see the anterior uveitis, we see probably some kind of reactivation of HSV. VKH, of course, fits perfect to these things, yes. But we do not see really infectious COVID-induced disorders. Can you accept this? Can you agree to this?
Yeah, I haven't seen it, but I'm just wondering if it's a retinitis, should we keep a differential of infectious retinitis? That was the thought here. When we are talking about toxo or viruses, different viruses, and also rickettsial fever and all these things. So will COVID come in the list too? We haven't yet seen probably.
Great. Well, I see that we also have Costa Rica now among us. Lite is here, Fernando. Lite.
Oh, really?
Bienvenido,
Well,
Lite.
it's a surprise
Thank
to see
you.
Lite in an uveitis meeting. Okay, great.
Thank you very
Well,
much.
he understands that he needs to teach you about that, Fernando.
I know.
Okay. Well, the next speaker is gonna be Miguel Bernier, and Miguel needs no introduction. Miguel, go ahead, my brother.
Can you see my screen well? Everything's good? Great to see you guys.
Yeah, but it's very unusual because it shows some snow.
Yeah, it's very unusual for January in Montreal. Very unusual, but it's okay. Summer is coming up in July 17th from 9 to 5, and we're going to be all happy. First and foremost, I'd like to thank Rubens Belfort and Luisa Nascimento and all the organizers, including Cristina Muccioli, this wonderful meeting. I'd like to say to my dear friend Manfred that it's a pleasure and an honor to be here with all of you. When I think about Manfred, I think about Rubens, I think about stars, and stars have this tendency of shedding light everywhere, but also, more importantly, have this wonderful quality of actually bringing more stars and more and more. And when I see Luisa Nascimento, when I see Cristina Muccioli, when I see my wonderful friend Claudio Silveira, I see the stars that have been produced under Rubens' umbrella, and Manfred did this so well. I'm also very pleased that the Pan American Association of Ophthalmology is well represented. Fernando is here. He's an icon for all of us. Gustavo Couto is here. Lourdes is here. And we have a great representation from the Pan American. What I'd like to bring to you today is the concepts that we have about ocular toxoplasmosis and how this evolved and how pathology helped the clinicians to make a better diagnosis, also to better understanding of the systemic disease. As you all know, 1908, Toxoplasma gondii was described by Nicole and Manso in Tunis, Esplendor in São Paulo. Bradyzoites were described, taxoites were described. You can see here electron microscopy of bradyzoites in cysts on the left-hand side, and a taxoite involving a retinal cell as a free form on the right-hand side. Of course, definitive causes are cats, and the transmission could be congenital or acquired. For many years, we thought congenital was more important. Thanks to the work of Claudio Silveira, Rubens Belfort, and collaborators, we now understand that the acquired disease is more important, is extremely prevalent in certain regions and countries. Clinical diagnosis is the way to do it because of IgG and IgM characteristics, and recurrences is the way that the disease keep moving up within the patient. Here you have a typical chororetinitis representing ocular toxoplasmosis. Pathologically, what's important is now that we have the OCT, is the perfect correlation. You see here a scar and an area of retinal necrosis. The retinal necrosis is important. Below and above RPE, differently from CME or CMV. CMV is only above RPE. And of course, in immunocompetent patients, you have a granulomatous inflammation in the choroid. The chororetinitis in immunocompetent patients is like that. Immunohistochemistry brought us to understand better the taxoites and bradyzoites and recognize them in histopathology. And Rubens Belfort III, with the collaborators, including myself, described a very important issue in toxoplasmosis, which I just described, which is the presence of necrobiosis between RPE and Bruch's membrane, which differentiates that type of extensive necrosis from cytomegalovirus. Many years ago, Claudio Silveira, Rubens Belfort, and some of us had an opportunity to describe acquired toxoplasmosis in families in southern Brazil. And extremely important that we not say very frequently is the discovered that taxoites and bradyzoites are found in the uveal tract in immunosuppressed patients. At that particular opportunity was AIDS patients. And then we start understanding why toxo to the brain and why CNS is involved, because now it's not an ocular disease anymore. Now comes from this circulation and now goes back to the circulation and then can cross any barriers Therefore, the spread of toxo with the presence in immunosuppressed patients because they don't have the granulomatous inflammation of cysts and taxoids is extremely important. One thing that always intrigued me was on the left-hand side, you have the 50% of absolutely 100% clinical diagnosis with the characteristic fundus pictures of toxoplasmosis. On the right-hand side, you have also 2 cases of toxoplasmosis, but the clinical picture is not characteristic. And in some countries and some regions, this accounts for 40 to 50% of the patients. How can we understand better the disease? How can we make the differential diagnosis? That's what I think pathology may help us. And we start looking at the importance of Toxoplasma gondii strains. We first described 1, 2, and 3. In Brazil, for example, type 1 predominates and it's very oculogenic. In Germany, there's one type 2 that's also oculogenic, but there's a non-reactive serotype called NR. And I think the clinical manifestations are a combination of the toxo strain, the genetic background of that particular population, and very important, the immune status of the patient. In our laboratory, we had an opportunity to look at those different types, and doing an invasion assay determined that type 1 is much more invasive than any other strain and much more oculogenic than other strains of Toxoplasma gondii. But that, of course, depends also in the immune status of the patient and the population where the patient is inserted. This is a great case. It's a great case from Brazil that was involved, 53-year-old Caucasian male, redness and ocular pain in the OS, left eye. It was very well known as having chronic bilateral uveitis, comes to the clinic because of the left eye, pressure is very high, was seen as a choroidal retinal adhesion who could not have a fundus picture. However, the right eye that did not bring the patient to the clinic showed a very interesting finding that I'm going to share with you right now. And this is the right eye with a typical area of retinal necrosis in the periphery, concentric, sharply demarcated from the normal retina. All the laboratory tests for different diagnoses were negative, and patient then was thought to have a bilateral uveitis, and particularly the right eye due to acute retinal necrosis. I think you all agreed that the clinical picture, I'm going to put it again, is very characteristic of acute retinal necrosis. The patient was treated accordingly. The problem is 1 week later, 1 month later, patient gets worse and worse and worse. The clinical picture now is much worse. The areas of necrotic retina are much more extensive, and also areas of hemorrhage. Patient continued to be treated as acute retinal necrosis for 1 more week, but then lost follow-up. 6 months later, comes back to the hospital at the Escola Paulista de Medicina with severe weight loss, pain in the left shoulder, cervical lymphadenopathy, and the biopsy showed a squamous cell carcinoma of unknown origin, probably lung, and metastasis in the liver, and of course, either metastatic to the lung or primary to the lung, and died 8 months after that diagnosis of acute retinal necrosis. In summary, patient had a diagnosis of acute retinal necrosis, a typical clinical presentation of acute retinal necrosis, then was diagnosed with squamous cell carcinoma of the lung, metastasis to the liver, died 8 months later, and the diagnosis of acute retinal necrosis was made. However, the resident was very intrigued with the case and asked the family if they could obtain the eyes for the diagnosis. The eyes were obtained. I had opportunity to look at the eyes. This is the left eye, and this is the right eye. They're identical with those extensive areas of retinal necrosis in both. And then both eyes have, again, extensive areas of retinal necrosis above and below RPE, minimal inflammation in the choroid. Remember, patient is immunosuppressed because of the cancer that probably he already had at the time of the diagnosis. And then clearly you can see here, even in the more normal areas of the retina, cysts and taxoids, and this is bilateral ocular toxoplasmosis. Very unique case. Ocular toxoplasmosis is a clinical diagnosis. The clinical picture, sometimes, as I said, 50% of cases is very characteristic. However, bilateral presentations are rare, but can be seen. acute retinal necrosis type of presentation can be seen. And what we believe is variation in severity of the clinical presentation depends on genotype of the parasites, as I said, and genetic heterogeneity of the host. The compromised immune system is certainly an additional factor responsible for the atypical and severity of the presentation, like in this case. What we did? ARVO 2 years ago, we decided to do a series of meta-analyses in ocular toxoplasmosis. Actually, it's not meta-analysis, now it's called systemic review with critical appraisal. It's a very sophisticated type of meta-analysis. The first one we did was, we got a study of 85 patients from 15 different countries and would like to see acute retinal necrosis like clinical presentation and cytomegalovirus retinitis like clinical presentation. Both we found are in adult patients. In acute retinal necrosis, they're immunocompetent and immunosuppressed patients. Of course, CMV, much more immunosuppressed patients. Initial presentation, RNA-like and CMV-like. Recurrences are much more likely to happen in the RNA-like presentation than in CMV. In RNA, or acute retinal necrosis presentation, type 1 strain is seen much more frequently. In CMV, both type 1 and type 2 strains are seen. And in acute retinal necrosis, lateral and bilateral, in CMV-like only unilateral. We thought this was very important to understand that the clinical presentations vary depending on the age of the patient, degree of the immunosuppression or the status of the immune system, and the type 1 or 2 of the strains. Second type of meta-analysis, even more interesting, was studying outbreaks. We studied 22 outbreaks in 9 different countries, and we want to do a protocol that how we should approach outbreaks. First, we want to see patients only with a typical presentation. We also want to see patients and determine the type of toxic strain in each patient, the mode of contamination, if the patient is immunocompetent or immunosuppressed at the time of the contamination, children versus adults, systemic clinical symptoms, and guess what? In most of the outbreaks we saw, ocular pain was important for the first presentation in case of ocular toxoplasmosis, which is something that we don't describe very often. And of course, we want to know the number of recurrences. I think studying the type, the strain, the immune system of the patient, and in particularly the region and the genetics of that patient are important to determine the presentation of ocular toxoplasmosis. And again, with OCT now and histopathology, we can understand much better the retinitis and the granulomatous inflammation of the choroid as a consequence of the necrotic retina. I'd like to finalize this saying 2 things. One, this is a picture that I like very much. It's a painting that is located at the Tate Gallery. And depending on the light, you can see only 2 people, the doctor and the patient. And of course, with the light of the computer, you can see the father standing here and the mother crying over the table. Just to tell you that, in my opinion, research and pathology always shed light to the clinical pictures. Our laboratory has a mission statement that we say we don't do research as an intellectual exercise. We do research because there's a patient at the end of the day. Once again, I want to say how privileged and honored I am of being here. I'd like to say to Manfred something in Portuguese. Manfred, Milton Nascimento is somebody that you know well, and he has in one of his songs the following lyrics. Amigo é para se guardar no lado esquerdo do peito, dentro do coração. A friend we keep on the left-hand side of our chest, inside our hearts. You are a great friend, you are a great example, and I want to dedicate this lecture to you with a great affection and admiration. It was great to see you guys. Thank you.
Thanks so much.
Thank you, Miguel. Great, great, great. Well, and now, next, we're going to have Alejandra de la Torre. We all know Alejandra de la Torre and been impressed by her, the research she does, and how she makes the field of uveites go ahead, especially toxoplasmosis. Alejandra, great to have you here. Go ahead, please. No sound.
Okay, thank you. And I want to thank Dr. Eloisa Nascimento and Dr. Rubens Belfort for inviting me to participate in this tribute to Manfred. When Eloisa contacted me, I thought of a scientific topic to include in this meeting. But instead, I decided to talk about my thoughts on how I've experienced Manfred as a great leader, friend, and wonderful human being. Of course, many of the aspects I will mention have already been said by Rubens and Christina. Still, I want to summarize the fingerprints and trails that Manfred has left in the ophthalmology community in the field of inflammatory eye diseases and uveitis around the world. I do not pretend to give exact dates and data. It is not a detailed biography of Manfred, but it is a tribute to the characteristics that distinguish Manfred and the path he has walked. Manfred is a leading professor of ophthalmology in Germany at the University of Tübingen. He specialized in ocular immunology and uveitis at Harvard Medical School and has become a great world reference in this field. Always think about the groups and projects he leads and making those around him grow and improve. When we talk about the characteristics that give each person a particular stamp, we can compare them with their fingerprints. The fingerprint that best distinguishes Manfred is his leadership. In addition to excellence, generosity, altruism, and inclusion, characteristics that make his marks permanent. One of Manfred's fingerprints has been participation in hundreds of meetings, both as an organizer of multiple congresses worldwide, as well as a remarkable invited speaker. Without a doubt, Manfred has been an outstanding president of the IUSG. And when we think about the legacy that he has left us, we must talk about a significant number of contributions and support in education and research in uveitis. This, of course, with the help of an excellent team. One of his ideas is the Venice course, which has had tremendous success and is one of his most distinctive projects. This course has also been extended to Africa with the help of Dr. John Kempen. Manfred has organized uveitis courses in countries where knowledge about ocular inflammation is essential and where no one else had thought before. Even in the difficult times of the COVID pandemic, Manfred has faced the challenge of continuing to bring education. An example of this has been the uveitis webinars, not only for uveitis specialists, but for all ophthalmologists. These webinars are accessible at any time and free of charge in the IUSG web. Numerous speakers from around the world have participated in these webinars, including speakers from Brazil and Colombia. One of his recent initiatives is the IUSG Ambassador Program, which seeks to support countries that do not have IUSG members and is an example of his altruism. Additionally, Manfred has implemented a patient support system that helps diagnose and treat complex cases of uveitis to the IUSG members and all interested ophthalmologists. Another of his recent ideas is the creation of working groups, which include scientists from other specialties such as rheumatology, infectology, epidemiology, considering that uveitis could be part of systemic disorders. So we are beginning with toxoplasmosis. Other of his legacies are chapters and books in ocular inflammation. And of course, his leadership as editor-in-chief of the OII, positioned as one of the most recognized journals in this field. He has held scientific meetings where, besides presenting topics of interest in uveitis, teamwork is carried out to make contributions such as the consensus recommendations for the diagnosis of vitreoretinal lymphoma, between others, leaving pleasant memories in the work team. In addition to his hard work and leadership, I want to mention some of his hobbies, such as the music, traveling. Manfred has traveled almost all over the world, not only for tourism, by lecturing and teaching in many countries. Photography. Manfred has a particular sensitivity and great sense of observation. And I cannot fail to mention that Manfred is a great friend with whom I have shared important and happy moments. And last but not least, he has also left a mark on his family. These are pictures of animal tracks taken by Manfred. Thank you, Manfred, for your generosity, for all fingerprints and trails you have left. You are a great leader who has left an indelible legacy in the history of uveitis in the world. As Ralph Waldo Emerson said, do not go where the path may lead. Go instead where there is no path and leave a trail. Thank you.
Wow, Alejandra, thank you so much. It's amazing that we had not planned for that. Everything came in a natural way. And I believe that your talk at the end of this part of the program really could not be better. Thank you so much, Alejandra.
Thank you for
Very
inviting
nice.
me. And
It's great,
thank you, Manfred.
Something very important for old guys is never forget the importance of learning with the younger generation, the young people. More old I am, the more I have to learn with bright people like you and so many others. Now I believe it's time to listen to Manfred, and Manfred is gonna say some words about perspective in uveitis and the field and thoughts about simplifying uveitis. Manfred, go ahead, please.
I wonder how I can activate that here. Sorry, I cannot.
Take your time, Manfred, take your time. You German are good in technology, but you can always ask for some Chinese advice if you want.
I think it is here in the upper left side.
Let me try this one. Yeah. So I'm absolutely overwhelmed, to say the least. Yes, thanks so much for everything. At the end, I think I only can talk a little bit about things, probably less about the future, more about the motto which you had, which was thoughts about today's, simplifying uveitis. I think this is a fascinating motto, and I always like that. In one of my first books, I cited Stefan Zweig, an Austrian author who finally went to Brazil, unfortunately died there during the Second World War. And this became a wonderful motto for my book. It says, "The most pleasant challenge in my work is deletion. Once, I recall, I rose with particular satisfaction from my work, and my wife told me I looked as if I had accomplished something really extraordinary that day. I answered with pride, 'You're right. I succeeded in deleting another whole paragraph and thereby found a more rapid transition.'" Well, simplifying uveitis, I think this is not that easy. But let me give you some very basic ideas how I start actually to see patients. And this is something which has at least not been mentioned today. Try to select, find classical forms. I think that's very, very important because that spares a lot of time. The next point is use the IUSG and SUN criteria. Definitely, I think they are absolutely necessary. I personally not big fan of something where planitis is associated with non-existing systemic disease. So I do not use this in that sense. And I'm also don't believe in anterior and intermediate uveitis. I think most of these cases are definitely let me see that here. Are definitely cases of intermediate uveitis. Let me go one back. Sorry about this one. For the other things, I would like to give a little bit some explanations. For me, I found it very interesting to declare leading criteria, and they should help to find probably associated disorders. And then I still believe that HLA-B27, I call it a typical HLA-B27 typical acute anterior uveitis. I think this is extremely helpful, at least for the patients, when you see how much diagnostics in such typical patients is done until they end up with a good treatment. It's a disaster. And finally, some of our latest projects, this is something the IUSG hopefully can continue in with our next ISO meeting, are the role of endothelial precipitates. So what are leading criteria for anterior uveitis? For me, it's simply laterality. Ask the patient first for laterality. If it's always the same eye, think strongly, very strongly about viral anterior uveitis. If it's a changing pattern, ping pong mechanism, think about the B27 typical acute anterior uveitis. If it's both eyes, then, which is quite rare, probably up to 10%, think about systemic disorders. That's for anterior uveitis. What about leading criteria for intermediate uveitis? This for me is age. Again, this is probably a more Western aspect. So be careful with this one in endemic areas, but at least in our world, we hardly ever see in children intermediate uveitis with any systemic disorder. If you please could exclude Tino syndrome, I think that's important. And if these are foreigners probably or have some kind of history, TB, especially in endemic areas. So I think I would not have shown this one easily in India. In adults, definitely, I think sarcoidosis, MS, think about these things, and these are the classical associated forms with intermediate uveitis, leading to quite early diagnostics, which is necessary. And for older patients, again, if you have someone in my age, it doesn't make any reason to think about multiple sclerosis. Yes, think strongly of intraocular lymphoma. I think that's very important. And then it becomes definitely a little bit more complicated for posterior uveitis. Think about localization, which means where is the inflammation going on in the eye? Of course, this is only a first impression. Again, if it's retinitis, it's mostly infectious, nearly exclusively. It's retinochoroiditis, it's nearly always, I think, always in Brazil, at least toxoplasmosis. And if it's choroid retinitis, of course, this is not sufficient. There you have to go on. And we've heard wonderful presentations of OCT and other imaging procedures. I'm very, very sure that with these things, you can find out much, much earlier these situations and what the real diagnosis is. Let me again focus on this B27 typical uveitis. It's a clinical definition. Again, you need an acute anterior uveitis and you need a unilateral changing laterality disease. And then you very often will you can ask the patients for preclinical sensations, and most of these patients have this. That means people feel something before the eye really becomes red. So in these situations, I do not care if people are B27 positive or negative. I see that there are more positive men than women. But the treatment then is independent of B20 positivity or negativity. It always starts very, very early with the first signs, these preclinical sensations, actually before the eye becomes red, with probably every half an hour or every hour steroids. And this is so helpful for the patients. I think most of you should really do these things. And I see the results here in Germany. It's wonderful that this system is taken over in the meantime. And endothelial precipitates, finally, you know, from the books, we have the typical location in Als triangle, wonderful. You have granulomatous diseases forming granulomatous precipitates. You also find these occasionally in HSV, rarely in others actually, but then you have the dust-like form with HLA-B27 typical anterior uveitis. You do not find granulomatous precipitates in this type of disease. So this is really important to differentiate. Fuchs classically, not always unfortunately, it's very uniform, distributed all over the cornea. And then you have the classical finding of centrally or paracentrally located endotheliitis. We are very sure that the endothelial cells play a major role in this type of endotheliitis in classical HSV or VZV anterior uveitis. Here you have these classical findings, dust-like under C. B, the classical viral form, Fuchs for D, and the classical granulomatous disease in A. So this now is work in progress, as you can see here. We start from the level of laterality, the lowest level here, and we try to separate bilateral, unilateral, and bilateral changing patterns. And then in the next step, we analyze the endothelial precipitates, and then from there try to find out if it's leaving the equator, over the equator. This actually has its own ideas, and maybe Fuchs or vitreoretinal lymphoma. So I hope that we can develop this scheme in the next IUSG meeting a little bit more, probably then also adding fundus changes. So this would be my big wish for the next meeting. Well, I only can thank you with a few photos from one of our older meetings. This is in Constance, I think, some years ago. And Christina, you recently mentioned this concert here, where we played the whole history with music, history of uveitis. And I will never forget that. That was great. Then we have met my friends everywhere. I think Danielle here in the meeting in the Inflammatio in Israel, and André in his own meeting here, and Alejandra with a background of Jerusalem here also in the Inflammatio meeting. And then the last time we were invited here to Sao Paulo, wonderful meeting, thanks so much. And that should show you the last one here. My love to the Iguazu Falls, which I think I've traveled to 10 or 12 times or something like that. Looking forward for the next one, and looking forward to welcome you to the 10th, finally 10th International Symposium on Uveitis, which will be now in Utrecht, 25th to 28th of August. It will be a hybrid symposium, and we are all looking forward to welcome you to this meeting.
Great, Manfred. Thank you so much for your talk, your vision, and your teaching. Now we're gonna have a kind of surprise for you, a video that Eloise prepared. It's not too long, it's gonna be just a few minutes. And after that, I'm gonna open up the microphone to the people interested in saying some words to Manfred. So the video first, and then we're gonna have an open mic. Go ahead, Elo.
I think you won't believe me. One of my favorite countries still is Brazil, definitely. Absolutely. You know how many countries we have in on our Earth?
Oh, I don't know how many.
Less than 200. So let's call it 196 or something like that, yes? And I've traveled approximately 130. I went to the army, and the only interesting point in the army was I was educated as a help person for doctors there. And that sounds really interesting. That was the first time that I got involved with medicine, with anatomy, besides a little bit biology in school. And I thought this is something really interesting. The next thing is to plan how to become a doctor of medicine. That's really tricky for me because I always hated school and I was not a very good person there at school. During our education, you have to have various courses, and one of them was I had to do surgery, of course, but there was an interesting person, quite a little bit aggressive person, but still very interesting, who did all the cataract surgeries in this small clinic. And he promised me to give a position there. I really found out very early that my interest is actually inflammation, some kind of inflammation, you know. I want to see, as a doctor, to see something changing. So I'm not really interested in diseases like some kind of destructions, something you cannot influence. So that also became clear to me. You're good if you can help these people. At that time, when I started in the beginning of the 80s, there came the first publications of HIV in the eye by Gary Holland, and that was something, yes, CMV in the eye, a virus in the eye. But later on, I also was very much interested in allergies, even dry eye. I think it's an amazing disease which is not treated correctly from most of the doctors because it's a real pain in the ass, a real dry eye, it's a disaster. In the middle is uveitis. Yeah? I tried to find out a little bit about uveitis. What does it cause? What is the treatment? Treatment is simple. It's steroids, more or less always, yes, if it's not a virus. And then to point out the differences. And I realized over the years that the differences were not really clear. So I worked especially also in the differential diagnosis of these diseases. Whenever you have ideas, it's a good idea if you have follow-up for these ideas, which can continue when you're not able to do these things. Otherwise, if it's only your idea and you think you are the most important person for this, better forget it. So in 18 and 20, we had Venice course in Africa, which was a huge, fantastic success. And whenever someone asks me for my religion, I think I love humans. I think education is a beautiful thing. Yeah? And you can, if you're clever enough, if you're good enough, if you learned your lectures, then it's a beautiful feeling to help people.
It's a war, and I know it will be a very hard war for me, but it doesn't matter the war. It matters who is the soldier with me, and I am a frontline soldier.
It's wonderful to hear that. You cannot believe how wonderful this is. Yeah, that fills my life. It's exactly what I want to do, yes.
Thank you so much, Eloisa, for that.
Thanks so
This
much.
was not prepared. This was not prepared by me. Actually, it was a surprise also for me. So this is not my merit. The only advantage I probably have is that I'm older, Manfred. And frankly speaking, my friend, from heart to heart, we are all in the same plane. We may be sitting in different rows, but we are in the same plane. And you have been the great leader of the field. So I thank you the opportunity of being here with so many people participating of this tribute to you. And now I would like to open the mic and have people interested say some words to speak up. Maybe if you could raise your electronic hands, I'm gonna make my life easier because you're gonna show up in my screen. But first, I'd like Manfred to say some words. Manfred, go ahead.
Yes, very, very short. Yes, this is amazing, definitely. But to be honest, this would be impossible without all of you. Yes. You know, as a leader, you cannot go alone. Forget it. Yes. If you're the head of a journal, without your reviewing editors, reviewers, you can go alone. You can close your journal and to check all these 1,100 manuscripts we had last year, something like that. Forget it. Same with IUSG. If I would not have such fantastic people with me in the IUSG who are always able not only to follow me, that's not the point again, yes, this is a wrong concept, I think, who always are progressive and add ideas and improve things. Without these things, such a group would not improve, would not have reached such a standard which the IUSG, I think, has now, yes. And you know, my presidency will finish with this year, definitely. I will help the new president, of course, in some of these projects I did, but some of them also have to be supported by other people. So let's see this, yes? Let's see what's going on with Venice and things like that. This will be the real importance then for the near future.
Manfred lost the sound. Manfred, we lost your sound. Back.
Well, for the whole time?
No, just for the end.
For the end, yes. Well, then I have to thank you so much for this great honor. It was such a fantastic meeting for me. I'm very, very happy.
Okay,
Thanks so much.
So we have Fernando Revolo now and Manta. Also some words. Fernando, go ahead. No sound, Fernando.
Thank you, Rubens. I'm really honored to be part of this tribute to Manfred, especially because I know he has so many friends and people that admire you, Manfred, and to be included in this group is just a tremendous honor. I have had the honor and privilege to know you for many years and work with you in different meetings at the International Uveitis Study Group, with the journal, and you have been so generous with me. Again, our conversations regarding treating patients, teaching, and life have been an inspiration to me. I've been amazed the way you love teaching and that has been a role model for me to follow. The amount of teaching, but the quality of teaching that you do is just unparalleled. And you have been somebody who has probably the most influential, one of the most influential people in uveitis in the world. And you have changed the way we treat our patients, the way we do our meetings. And I'm looking forward to many, many more years of your influence, even if not as a president of the society. You're always going to be an amazing advisor and friend for many, many of us. Thank you so much, Manfred, for all you do.
Thanks so much.
Thank you. And we have now Mamta and go ahead, please.
Well, I'm so short of words here, actually. This is just too beautiful. And Manfred has really brought the world of uveitis together, I can say that. It's like meeting everybody, knowing so many people. It's simply beautiful. Thank you so much.
Thanks, Mamta.
Knowing that Derek Smith now plays an very important role, I wonder if Derek would like to say some words also, Derek?
Hi, Derek.
Thank you. Hello, everyone. I'm probably one of the people who hasn't known Manfred as long as many of you, because I only met him at the Venice course in 2017. So that's about 5 years ago. But to say that he has changed my life in uveitis would not be an overstatement. The amount of guidance that I've received from him, the number of opportunities that I've had because of him, the places I've seen with him, you know, I don't know how many of you have crossed the Congo River with Manfred, but that certainly is something I'll always remember. And we've shared some really amazing conversations. And as all of you know, Manfred is not just about uveitis. I mean, his knowledge of music and so many other aspects of life is simply encyclopedic. It's almost like there's not anything he really can't talk about. And that has really fascinated me, and it inspires me. And for me to have an opportunity to help him a bit with the journal now is an extremely great honor, and something that I'm sure I'm going to have a very steep learning curve on, but I hope to be able to do a really good job of that, and to see that the journal goes where Manfred would like it to go. And yeah, I'm humbled by the opportunity to do that. And thank you to everyone for contributing today. I think the talks were really great. Alejandra, your tribute was fantastic. And looking forward to seeing more of you in real life. That would really be nice. Thank you, Manfred.
Derek, you're such a brave person. I hardly can imagine anyone from the audience who would join me to Congo and Nigeria. This is really something, I tell you. Yes, it was fantastic. These things, amazing. And tomorrow we will start with OII.
Look forward to it.
And there is also kind of honorary Brazilian fellow. There is Manabo Mochizuki. Manabo, you are always in my heart. You remember me, Bob, and the past and the future. Please go ahead.
Manfred, thank you very much for your great leadership. And I've been in this uveitis society for many, many years, but I've never have such a excellent and great leader as you, and I'm very appreciate. Thank you very much. And this is a great meeting. Thank you for all.
Manabo, thanks so much. But you're, again, one of these persons which always gave me such a super, super strong support in what I did. Thanks so much. Yes, without people like you, we would not have achieved as major parts of what we did for the journal, especially, but also for some of these things like the vitreoretinal lymphoma. You played a major role. Yes.
Thank you.
Thanks so much.
And I'm enjoying working with you very much.
So beautiful.
Yeah.
Well, I see many friends here, many important leaders. Justin Smith is there, Professor Chisholm Park also. I wonder if they would like to say also some words or not. Justin, always good to hear the Australian accent.
Yes, so I'm here, Rubens, and thank you for this really outstanding meeting. And Manfred, I want to say herzlichen Dank.
Gerne geschehen.
Vielen Dank.
Gern geschehen.
I want to thank you for many things, for your intellect, for your enormous energy, your kindness and affection, and as everyone has already said, for your outstanding leadership. You're so much fun on top of everything, and I will never forget our wonderful evening at Unsichtbar, the special restaurant in Berlin. So thank you so much, Manfred. I have a lot to thank you for, but I will just keep it short tonight. Thank you.
Thanks so much.
Thank you, Justine. Great.
Hi, hi, Manfred. Thank you so much for all your leadership, and I think you're a guy of great ideas and great perseverance and amazing and abounding energy. And I think, you know, we had spent so much time planning for Singapore, and I'm sorry that we couldn't see it through, but certainly we will be together in the Utrecht meeting this year. And I just want to thank Rubens as well for this wonderful meeting, which I really enjoyed. Thank you very much.
Thank you. And I know that the meeting last year, right, would be in Singapore. We all look forward to meeting there. Maybe, Manfred, after Netherlands, we would have Singapore?
We changed ISU with Inflammatio. So the original idea was that Inflammatio goes to Netherlands and ISU to Singapore. But now due to all these epidemic things, I think you've heard about this, we changed to ISU to Netherlands, and in 2 years, in 4 years, we plan to go, is it 4 years? I have to check, sorry, to have the Inflammatio, then definitely in Singapore, definitely, yes. There was such a lot of work, student fake. This is actually, this has to be paid for, definitely.
Okay, great. Well, I don't know if there is anybody else who would like to talk. I see I have many people here. Kilstra, hi.
Hi, Rubens. Good to see you. And of course, Manfred. I've known Manfred for quite a long time. I think I started to know Manfred during the ETAL meetings, which were really fabulous. As Manfred already said, joining basic scientists with ophthalmologists, rheumatologists, etc. I remember the meetings with Wayne Stryline at that time. It was really great. And of course, well, the things that I remember very much are the times that Manfred and I were in China together, partying with the students of Paiseng Yang during the night. That was also great. I would also like to thank Rubens for this great tribute. I think I'm one of the few people here that was also at the Guarujá meeting. That was one of my first IUSG meetings, which was also great. And after the Guarujá meeting, I traveled with Aniki Rotova all the way to Foz do Iguaçu, and I now know why Manfred. I only visited it once. I think I heard that Manfred was there about 10 times. Well, I'm really very, very jealous. Well, of course, I think Manfred has done. Manfred, you did an excellent job on the journal Ocular Immunology and Inflammation, a journal which I started in the early 90s from a very small publishing company in the Netherlands, and which is now has grown as really, well, the journal on ocular inflammation, which is being published by Taylor and Francis, which is really well. It's really doing very, very well. And I think what Manfred, what you have done for the journal over the last few years is really tremendous. And over the last few weeks, my contact with Manfred has intensified. We share the same love concerning music, and that has also been very great. Manfred, thank you again for your leadership in this field, and of course our friendship over the many years. Thank you.
Thanks so much.
Okay, well, I think it's time for us to conclude. It's 11:25. I'm gonna now ask Heloísa Nascimento, as president of the Brazilian Uveitis Society, to close the meeting. And again, Manfred, thank you so much. Keep kicking, my friend, keep kicking.
I do that.
Dear Manfred,
Heloísa, go ahead.
In 2011, you and Marina gave me the opportunity to go to the Venice course. That was a breakthrough for other uveitis specialists in Brazil, and many patients due to your to the opportunity that you gave us with the indication of Professor Belfort and Cristina Muccioli. So I thank you so much, and we are going to keep treating our patients the best way we can. And I ask everybody to praise you, please. Thank you.
Thanks so much to all of you. It was a wonderful day for me.
Thank you. Bye-bye. Goodbye. Bye-bye. Good night. Good afternoon.
Bye-bye.
Good morning. Bye-bye. See you soon.
Thank you, Rubens. Thank you, Lois.
Thanks so much for everyone.
Thank you, Dr. Manfred.
Thank you, everyone.